to get that back. Not to talk about you want to be profitable. So there's also the question of low per income and low capacity. Because more often than not, you have somebody into my office say, treated, right? And we get that a lot. And in fact, more often than not, because we often represent the corporates more than individuals. What we see is people in the hospitals are coming to us that, oh, this person, I mean, we get this call every week because we represent quite a few healthcare organizations. We get this call every week. Oh, somebody is threatening to sue. I think the last one that was very funny was that some old man in his 90s wanted to go for his surgery and wanted to sign up himself. And then his children did not want him to do surgery, and the children were threatening our clients. And we're like, people are raising, legal issues every single day. And so those are just some of the things. So of course there is a question of maintaining standards. The third thing will be the exchange rates. I think when I started legal practice, the exchange rate was probably less than 100 the naira to $1. Now we know where it is. So imagine somebody had taken a foreign exchange loan at that time and is paying now. So you can see that there is a lot of issues with the exchange rate. It seems like something small. Every additional naira or kobo that is added has a big impact on healthcare. The next thing will be the wide disparity between the urban and rural areas. I'm sure most of us, we're all based in Lagos. Is there anybody who isn't based in Lagos in this room? Okay, so the next thing is that, did we all school, or at least before university, were we all based anywhere else apart from anybody? Maybe from any other place. Okay, I can say that for myself. Talk about Japan. As people Japan to the UK and the US, who are from the rural areas, or what we will call non-Lagos to Lagos. So there's a wide disparity. One of my clients often says that after you leave Lagos, Abuja, the quality of healthcare drops significantly. Apart from maybe those ones that have very strong public healthcare, like maybe the Kano teaching hospital is very strong, right? Apart from those that have very strong public healthcare institutions, once you leave Lagos and Abuja, even Abuja, the jury is still out on that, of course, because it's a question of personnel much more than they have structures, but whether personnel to run is another thing. So we have the rural-urban disparity, and then we talk about profitability. We call it the health economy because it's expected to be profitable, right? And because of all the difficulties we have found, it becomes increasingly difficult for health to be profitable. I was in a meeting with some of the HMOs, right? And a number of them were saying that for the past 3 years, they've not really been able to break even and be profitable. I know you in the health insurance, you may be profitable, but quite a lot of health insurance companies are struggling once it comes to the profitability. Of course, people are unwilling to pay, some of the higher premiums. I think it was Ilera Eko that was saying that with the 5,000 cover, a person can get a CS, or is it 50,005? I don't know if, you can get a CS, paying 5,000. What world can that be profitable, right? It's unlikely. It's not, but of course, that has a lot of comments streaming in, so at least that's for the benefit for the people. But you can imagine competing with that as a private, that emergency cesarean section is not elective also, but even if it's emergency, you assume that it will be much more expensive than that. Then withdrawal of international support. Recently we have seen a lot of international support withdrawn. I'm sure everybody who is on social media I've had friends who unfortunately have lost jobs because, they are, contract that they had held for many years was not renewed this year. So so because there's a, there's a gap in that, of course, there is the need for more investment in some of those areas, and they are going to cost more. Then political uncertainties. There are quite a few times that as we move, as one government transitions to the next, I think it was Akwa Ibom that the report recently came out that there was this, was it 40 or 50 billion naira hospital that was, it used to be one of the best some 10 years ago. I think it was under, I've forgotten the name of the governor, pardon me. Now, there was a complaint but the hospital was no longer as functional as possible. I know it used to have cancer care, it used to have cardiology care, and Akwa Ibom, right? Yeah, I saw that. Yes, thank you. Now, it's now down the drain. I don't know how true that is, but at least the report is indicative of the fact that, that investment has probably, tanked, and the people who invested in it may not be able to recoup. So these are some of the things we have to balance, right, from the legal perspective. While it may look like, oh, we are just saying, oh, we need to make laws to make perfect investments, but these are some of the factors that we unfortunately have to grapple with. So we're going to talk a bit now. Please, next slide. Next slide, please. We're going to talk about some of those factors that we need to consider, right? So I'll group this into legal factors, regulatory factors, policy factors. From legal factors, right, when we talk about legal factors, we're talking about both case law, statute. Okay, sorry, is anybody familiar with the term case law? Any ideas? You don't have to be right? I'm the lawyer, you are the medical personnel. Is there any idea of what a case law is? Okay, so call it case law is that a judge, when a judge pronounces on a case, it is considered a law, in the sense that every other person who has the same set of facts should get the same decision. So that's why we call it, it's called judicial precedence, right? So it's also a type of law, right? So for instance, if a judge says that, the one we probably are all familiar with is maybe the election cases, and they say, okay, if there is a rift within a, remember that did not come out from election. It came out from, meaning that same principle will be followed. So then we have regulatory. We are a number of regulators all over the place. Healthcare is one of the highest regulated economies, right, in the world. It's regulated at every step of the way. Of course, for good reason. So we're going to talk about regulatory factors and policy factors next, please. So some of these factors that we'll be talking about are not just factors investors must consider. It's factors both the person investing and the person receiving the investment. And while we understand that there's a place we want to be, we have to always find, the place right now that we can maneuver, meaning that we still have to do everything within the habits of the law while we are trying to get investments, while we are trying to invest. Next slide, please. So we're going to talk about some of the things people have told us they want, right, in terms of investment, and we'll give a bit of where we are and where we hope to be. One of the things is clear regulator, to have certainty when it comes to regulations. I think one of the things we find out is that sometimes, not all the time, regulators can be a bit ambiguous, right? Can be, okay, they'll just give you like a general guideline, and we understand they are talking to millions or thousands of people who want regulation, but sometimes we want more certainties. When you compare some of the legislation abroad here and how they drill down, many times when we are having clients that we are, interfacing with regulators, many times you have to literally know the regulators and be able to call them often. But if people don't have that relationship, it becomes very difficult for you to, answer some of the questions, and there are many questions. The second one will be the regulatory timeline. I know the, what's the name of this act? The Business Continuity Act. I know they say, okay, once a timeline for doing a thing has passed, it's automatically deemed to has done, but we know that hasn't really worked for us. But many times, for instance, if you want to register a new drug product, how long does it really take? We've had clients do it in months. We have had clients that maybe have been struggling with it for 2-3 years before coming to us. But there's a lot of uncertainty, when it comes to some of the timelines. And quite honestly, a number of times regulators do not commit to a timeline, right? They just tell you, come and register, come and process your documents, or bring documents. They don't commit that, okay, once you submit this set of documents, it will come in. You'll get your certificates in 3 days. Then, of course, we have the issue of outdated laws. I'm sure we are all familiar with some of the, very, very old laws we have. There's some improvements over the years, but there are still a lot of laws. In terms of predictability, one of the things we notice is that governments can be very emotional, right? I don't know if we recall the withdrawal of codeine, abrupt withdrawal of codeine importation in 2018. And while a lot of, people, of course after the BBC interview, while a lot of people felt like, oh, it was a great thing, I was thinking then, and I had this conversation, in fact, almost had a fight with some of my colleagues about how this impacts investments. Imagine I had taken a loan or I had gotten investment to produce some drug codeine, and started telling me that that loan, that importation I have, permits I have gotten, is of note, it cannot be used. So it's important that while governments try to, respond to the tenure, within the society, it's important that they are also conscious of the impact on investment. So next we'll be talking about private-public partnership. There needs to be some clarity. Is there anybody here involved in any form of PPP? Yes, any form of PPP. Okay, thank you. So what we've seen is that sometimes people are not very clear. And I won't just blame this on the government, right? There's quite a few legislation when it comes to PPP. There is the Infrastructure Concession Regulations Commission Act. There is the Public Procurement Act, which everybody uses, but it has some applications to PPP. There is some fiscal responsibility. There are many legislation. But I find out some of the that lack of, right? There is and of course, a lot of people feel strong, sometimes from the investor side or the concessionaire side or from the government side. There is a lot of, so for instance, I remember we reviewed one of those concessionaires who, I think they were building a 200-bed hospital somewhere in Nigeria. And you can imagine, after we had finished negotiations, after signing, after everything, the government came to us that they want us to pay ground rent. Can you imagine? They still own the property, right? But we are just, with upgrade of the hospital, and they are telling us they want to pay ground rent. And it became one of the things that we were able to establish was some of the things we had put in the contract, and it really helped us because apparently there were other people who were entering into PPP arrangements and were still paying ground rent, and it became clear that quite a lot of people just think PPP agreements are just any other contract, right? So one thing, while we want legal certainty from the government, we also need to do our part as well. And thankfully, we have seen that in recent times, the courts have been more inclined, to uphold PPP agreements. There was once a time when, government, the judiciary seemed a bit swayed by political, pressure. But increasingly, you see that this has not been the case. One of telecoms. This was a case related to FAN, that's Federal Airports Authority of Nigeria. They gave somebody a contract. There was a political falling out. They now wanted to try somebody else, and blacklisted, and it just became a mess. But eventually went to court, and the PPP, the concessionaire won. So we have seen that, increasingly there's some assurances. So while we are happy about that, we also need to do our part in terms of clarity. Next slide. I'm sorry, let me try to run through the next couple of slides so that we'll not spend too much time on this. Then the next was land and infrastructure security. If we have ever tried to buy land anywhere in Nigeria, you will be amazed by, for instance, just how much documentation you need to put together. And one thing we found out is that, sorry, excuse me. One thing we found out is that mostly when you have maybe built a structure on the land, somebody comes to start claiming ownership of some segment. In fact, we are currently handling something where our client's factory had been built more than 40 years ago on a particular property. Of course, it's a factory, so it's outside the main, outside of the outskirts of Lagos. For two families to come and say, oh, the family you bought it from, not the family that owns land, and it's currently in court. I mean, we have good reason to wait. I can't assure you. So even that you want to avoid altogether. So we want some legal certainty in terms of land security. We want like digitization of the land registry. I know that so many states have attempted. Aegis has attempted with Abuja, but despite that digitization, there is still a lot of problems. We still record a lot of problems with it. So we want some accuracy and some certainty when we come to land transactions, because land is amongst the, mostly if you are for healthcare, a lot of us, we are in the primary or secondary healthcare delivery. We cannot afford to, situate it at the outskirts. We want to, situate it within, where people will easily have access to. So we also want a lot of security in terms of land and infrastructure. Tax incentives. I think, next slide please, tax incentive. Over the years, we've gotten piecemeal tax incentives in terms of, for healthcare. I remember during the COVID periods, they say, okay, COVID medication, it will be tax-free, or COVID, all those testing kits, there'll be some tax waivers for it, which is great. But we know that profitability of healthcare is very, very difficult. So of course, we all want tax incentive. The only thing I would say, because I know there's a lot of conversation going on about tax incentive, but a lot hasn't materialized, is that while we will welcome the idea of the government easily saying, I'm not collecting taxes on some medical equipment, it's also important that that is codified in law. And I will give you an example. I think it was in Kenya, it was a really, I don't know if we are aware that when you do not pay your taxes, it is a debt, meaning that the government can collect it at any point. It's a debt you owe. Right? It's just like, yes, if you omit to pay your taxes, if you had omitted to pay your tax in let's say 2022, even if the government discovers it today, the government can come for that money that you did not pay, and it's a debt you owe. So I think it was in Kenya or one of those other countries, what we saw was that a government had woken up and said, okay, don't pay taxes. It was not for healthcare. Don't pay taxes. Right? And let's say they did that in 2022. There was a transition in 2024. In 2025, that's the next government, the next regime that took over, then looked back and said, look, what they did was just pronounce. It was never a law, and a circular isn't enough. Can you overturn a legislative provision by a mere circular? There's something in law we call hierarchy of laws, right? The highest type of law is your statutes, is your legislation. That is, the House of Assembly or the State House of Assembly have agreed, and then the President signs assent. That's the highest type of law. The next type of law is like a regulation. Regulation is subsidiary statutes made pursuant to a legislation, usually by an executive. Then you have, it goes down, then you have somewhere called all those circulars that you see. All those circulars, NAFTAC released a circular. It applies to you, but it doesn't have the same status as the law. So if there's any inconsistency, the highest law is the Constitution, pardon me, I omitted that. The highest law is the Constitution before the State House. So now what they said was that since there was a statute that said that you have to pay maybe 2% taxes, can you come back and, can a government just by saying, oh, in a circular, without amending the law? So it became a big issue, and eventually people had to pay. Some people went to court. There was a lot of legal but at the end, eventually paid. So while we push for some tax incentives, I think it's important that we don't just push it at the executive level, which is what we see often happen. We also push it at the federal level. At the legislative level. The next I will talk about will be intellectual property and innovation. Um, Intellectual property is one of those things that a lot of people take for granted, right? Okay, show of hands, how many of us have registered our corporate name as trademarks? Or have you registered your corporate names as trademarks? Or we are not sure. There are some here that I'm sure of because I have access to some information about them, but I can't say for all of them. At least I know my company has. So nobody is aware whether or not their trademark has been registered. Right? So I think it's something you should always go and look back at whether your trademark has been registered. Now I'll give you an example. We once were on the the investor side in one of the transactions, and apparently there was this it was not a healthcare organization. There was this it was a healthcare organization, but I think it was more of telehealth. And they had gone ahead to finish negotiating the transactions. And somewhere along the line, we found out, when we were doing our due diligence, we found out that some of the company had not registered its trademark, right? The person that we wanted to invest with. And it wouldn't have been as bad as the fact that somebody else was now had already initiated registration and was trying to take advantage of some of the trademark, rights, because, there's what we call first to file rule in Nigeria, the person that files first has some rights. There may be common law rights. Common law rights are rights by virtue of use. But usually, in terms of proving your rights, it's easier to bring out a certificate than to start telling the story, how you're using it for 1,000 years. So, apparently, because of that, because there was no trademark registration, no application, eventually we had to crash the price because we had to take into consideration that we are going to go into while we are investing, we are going to go into legal battle with this person that is already encroaching on your right because that person had taken the step to file first. So I think that's one of the things we have to find, make sure that all our IP rights, and this is the same thing for telehealth, right? A lot of you are involved. I mean, if I think most of the insurance companies now have some sort of telehealth provisions. All that has some legal underpinning, and it's always important that. Oh, sorry, you cannot hear me. That legal underpinning, and it's essential that we take advantage of that. Investors are looking that's one of the things we do during due diligence. While we are doing your due diligence on your land, we are doing your due diligence on your whether you have proper contracting documents with you. We are also doing due diligence on it. And this is becoming increasingly important. Sometimes the IP rights is not just IP rights from the trademark registry. We also IP rights. We have to think of the IP coloration. If you have tried to register a NAFDAC, imagine I don't know who is there anybody in the pharmaceutical industry here? Anybody related to pharmaceutical industry? Okay. So, for instance, please just give me a name of any drug that is pretty common. Not the active ingredients, the brand name. It's tricky because it's a chemical compound that was modified. Yeah, well, it's a trademark, right? So imagine somebody tries to register qua name, right? The truth is that the current NAFTA, go ahead, even if it's the same product, qua name. Like the fact that NAFDAC is not a regulatory agency for trademarks. What they tell you is that if you want to fight it, go to court. And that is what you see. So we have to not just trademarks from the going to register your trademark. There has to also be some protection in terms of the regulatory agency, such as NAFDAC. So what we try to do is to have, warranties in some of our contracts when it comes to, for instance, if we are talking from the investor side, despite the fact that we are, investing or we are taking equity, we want to have some warranties from a lot of outdated law. One of the interesting, because of our copyright is fine. Our copyright be, copyright is constantly updated, but unfortunately, patents and trademark, the Patents and Designs Act, I think it dates back to 1970. The Trademark Act is 1967, yeah, 1967. So that shows how ancient some of those laws, a lot of things have happened. But despite this inadequacy of the laws, it's important that we take advantage of what is currently existing. I'm surprised nobody knows whether they are trademarked. I'm sure some of you, have had your trademarks registered, but please go and check, right? Whether or not you have trademark rights registration could make a difference in terms of hundreds of thousands of dollars as to whether or not you get the full fee when somebody wants to invest in your company. Another thing I'll talk about the data protection and information systems. There's been a lot of news about data protection. Are we aware of the Data Protection Act 2023? Yeah, 2023. Recently, I'm sure you probably heard of the $200 million fine to Facebook in Nigeria, by the way. This happened in February or March, right? That was although the investigation had taken almost 3 years. I think 3 years. But that's just an example of how data protection. And, we should be aware that healthcare data has an extra layer of protection, right? More than just the regular, what is your name? It's called highly sensitive data under the Data Protection Act. So the penalties for failing to comply with the data protection laws is much higher than even data protection. Whether register or there has to be some data protection, because it could make a difference between your profit and not if you are fined, and fines are usually very huge. Under the Data Protection Act, it is 2% of your turnover, of your gross turnover, meaning that all the income you get, whatever it is, your doctors, or you bought lab, or you bought a lab equipment, or you are returning income on an investment that was made into your organization, or you are paying your debts, or you are paying your interest, they don't care. Whatever has come into your business, 2% of it, that's an insane amount of money, right? It's not 2% of your profit, let's be clear, it's 2% of your gross. So please take your increasingly when investors come into Nigeria, don't, and after they are now ability. Another thing I would say is that I don't know if anybody is aware. Have we done? Is there anybody who is confident there? Thank you. Finally. Well, okay. Sorry, what organization? Avon HMO. Okay. Is there any organization that has done their data audit this year? So I cannot even talk about data protection assessment, and I'll talk about both. So there is a mandatory requirement under Nigerian law now that you perform your data audit, meaning that it's sort of like an analysis of how you use data. Because the idea is that since healthcare data is since any data, it doesn't just apply to healthcare organizations, but healthcare organizations are called, deal with high, so they have a higher, you're supposed to come up with that. This is where I use data, this is where I let's say healthcare data, sometimes financial data, and all that information, there has to be they have to essentially say that you are correctly protecting it, right? So it's mandatory that you have a yearly data audit, and subsequently, yes, you can just update, but that first data audit must be done, and subsequent years. And what we typically do is that when we conduct data audits for people, we then do training so that if, for instance, there has been any breaches in your organization, breach could be a lot of things. It's not just somebody hacking your system. It could also be that maybe they sent an email to, to somebody else. If there has been a breach, that can be stalled next time, and there are procedures put in place. Then we have to then talk a bit more about data protection impact assessment. If you run a telehealth organization, or if you run any mechanism where you collect a lot of data, there's a mandatory data protection impact assessment, meaning that you have to do an analysis of how it impacts the people that you are receiving data from. So as I said, please take your data protection. They are going after everybody now. And they are, right now, like the Facebook one was the collaboration between FCCPC and NDPC, that's the Nigeria Data Protection Commission. They collaborated, and it was an investigation. And right now, we have seen Domino's has fined almost every organization, and we've seen a lot of. So once more people comply, they will come for the healthcare organization. And somebody mentioned this project. That we have some reason in that now. So he bought a cup of and she won. So you can look up. So why when they will, for if you say you have a headache, they will. Is it like also watching that you have certain things in place? I think that's the last slide. Yeah. So I think let's run through to the last slide. I'm going to talk about some case studies. About this. I think that's about it. These are some case studies of some countries, what some different countries have done to help healthcare investments. Rwanda, they had this big, beautiful, tax incentive, which was as a statute, not just something that was said. So you have a 7-year tax break if you tax holiday, if you give an investment of over $50,000, right? That is what they wanted because it was one of their priority areas. Healthcare. So Nigeria, of course, we have a lot of PPP frameworks. I think people take the Nigeria's PPP framework for granted. Other countries, not every African country has a PPP framework. And we have both at federal and state level, which is really good for us, meaning that you don't have to go for federal mines. You can negotiate with the state governments as well. Then Kenya also is trying this digital economy, digitizing and everything within government. They want you to be able to get all your licenses from your home, right? It hasn't fully worked, but it's a step in the right direction. It just means that, it will ease investments. Last slide. I think we are going to the last slide. I'm sorry, I'm out of time. So in conclusion, creating a conducive legal environment for healthcare in Africa is not just just for us to do, or the government to do, is for everybody to do, and it's a strategic imperative. So while we think of legislative impact, we also think of what we can do from our end. So last slide, the conclusion then. Last slide is just a bit. And just get a bit of understanding from this perspective. Thank you, everyone.
Good morning, everybody. Good morning, everybody. Let's all give like a quick smile so that we show we're happy to be here. Good morning once again. Thank you very much for a wonderful session. Thank you for those that are just coming in. We are the Pan-African Health Alliance Summit. It promises to be a very wonderful time, like we just experienced. So quickly, we're going to be moving to the first panel session of the day. And then the first speaker spoke a lot about like the PPPs in Nigeria and how it is highly underutilized, right? Comparing to a lot of African countries, we don't realize how much power we have in like private-public partnerships. So the next panel session is going to be about driving innovation and access through public-private partnerships. So to give like a quick story before we go into the panel itself, how many of us are healthcare professionals, like medical healthcare professionals? Like you went to school, you studied medicine, you know those emicita for years. How many people? Okay, we have quite a few number of hands. How many people in school did you get to experience something outside of medicine while you were in medical school? Nice. Okay. How many people had experience to like the legal framework of things while you were in medical school? Okay. All right. We're getting somewhere. Now, outside of school, we see how healthcare as itself is not just limited to the medical framework of things, right? And then you hear PPP and you think it's just, healthcare in itself. Do you get? But then in the panel session today, we're going to explore a lot more how private-public partnership goes beyond like institutions in healthcare to institutions outside of healthcare itself. Do you understand? Today we learned how important it is to have a good legal framework, even in the midst of healthcare investments and all of that. So, to start our panel session today, we're going to invite a few of our speakers, and then we're just going to read. Can we all hear me? Okay, so we're just going to read their bio. So our first speaker for today is Dr. Adeyinka Adeyemi. So Dr. Adeyinka Adeyemi is currently the Group Head Medical Services for Avon HMO. He is an astute medical practitioner with over 10 years experience, and he obtained his Bachelor's of Medicine and Surgery from Olabisi Onabanjo University. He has a diploma in healthcare innovation and entrepreneurship from Duke University, North Carolina, USA. And he is currently building capacity building and sustainability from Deloitte, UK, a certification in management health, and he is a physician executive with experience in multidisciplinary settings, both home and abroad, with a career focused on strengthening health systems, specializing in the deployment of quality healthcare delivery services. Please, with a large round of applause, let's welcome Dr. Adeyinka Adeyemi as he makes his way on stage. So our next speaker today is Bukola Odoi. I'm sorry. Odoi. I'm so sorry. It's a beautiful name. So Ms. Bukola Odoi is the Special Advisor, Office of Public-Private Partnerships, Lagos State. She is an accomplished legal expert, a senior public servant, currently serving as the Special Advisor to the Lagos State Governor on Public-Private Partnerships. In this role, she has designed an execution of informative projects such as the Smart Health Information Platform, the Red Line Rail Mass Transit Project. More currently, the signing of a waste management processing concession, playing a crucial role in enhancing infrastructure and public service across Lagos. Under her leadership, the Office of collaboration between government entities and private sector stakeholders, fueling economic growth, expanding crucial infrastructure, and improving the quality of life for Lagos residents. She has been instrumental in negotiating agreements, including the Memorandum of Understanding with China's civil engineering construction company for the Lekki Ekpe Link Bridge, Lekki Ekpe Airport. Let's give a very large applause to our speaker. So the next person on our list is Mrs. Olufalade. Believe I'm Yoruba. All right. She's the healthcare. She's a financier with over 18 years experience in management consulting, public health, and healthcare infrastructure financing. She started her career with KPMG Nigeria, where she provided strategy, financial, and project management advisory services to clients in the infrastructure, government, and health sector. Let's give a big round of applause to our speaker. Our speaker is Lola Miriam Ali. She is the COO, Upline Care Group. Okay, so she's the executive director of Upline Care Group. She's an experienced healthcare leader, a first-class economics graduate from Newcastle University of Cambridge, with a proven track record in strategy, growth, and transforming complex healthcare systems into value-generating entities that has served communities with excellence and compassion. With over of experience, she has been providing technical assistance and advisory services to international organizations and governments. She demonstrates exceptional skills at driving robust P&L performance, developing public-private partnerships, and navigating evolving industry dynamics while improving healthcare accessibility through innovation, strategic partnerships, and technology integration. Let's give a very big round of applause to our speaker today. Thank you for joining us. Next person on our list is Mr. Olufemi Akingbade. He is the Executive Secretary, Healthcare Federation Society. He is a health technology professional, currently serving as the Executive Secretary of Healthcare Federation of Nigeria. Pivotal role in private sector engagement and health system strengthening across Nigeria. Previously, as the Executive Secretary of the National Health Authority, saw strategic initiatives and deepening health insurance reforms. Coverage. He is currently recognized technical expertise, visionary leadership, background that spans financial administration, ICT innovation, and healthcare management. He is also a fellow of the Nigeria Computer Society. His appointment at HFN is seen as instrumental in bridging the gap between the public and private health sector to deliver efficient, affordable, and accessible health across the country. Please let's give a very big round of applause to our speaker today. Now, this panel session is going to be moderated by the doctor himself, Dr. Akingbola Adewumi, who is editorial member, Infectious Disease, Cambridge University. Let's give a very big round of applause as he comes to moderate this panel session. Please, let's not stop. Let's continue till he gets, yes.
Everyone, am I quite audible? All right, so please see, just in case you cannot hear me, but just call my attention to it, and I would increase my volume and check if there's any technical issue with. All right, so thank you everyone once again for joining us at this event, and I will be moderating this panel session. Topic is driving innovation and access in healthcare through public-private partnerships. So as she said, I am Adewumi Akingbola, and I am a medical doctor, and I also happen to be a couple of other things. But one area that I'm actually very passionate about is actually access to healthcare innovations, especially in low to middle income countries like Nigeria, right? Because I've seen that the dynamics to innovation access is different in the high income countries versus the low income countries, and their strategies, their methods cannot be directly copied and implemented here, right? So, and that's why I've been very interested in this area, and I'm very lucky to be discussing with panel experts, right, in this subject matter. And I really like that we take one notes, and most importantly, we can keep our questions so that when I'm done, we can also ask questions from them. So, thank you very much for joining us, Dr. Adeyemi, right, and Mrs. Bukola, right, and Mrs. Funke Farade, and Mrs. Lola, just Lola. All right, thank you very much, and Mr. Femi. All right. So, my first question is going to be a general question, and it's one that I'd just like to get out general. Drive both innovation and access. Single most critical factor for a successive PPP.
Okay, or should we do ladies first? For me, the most single factor that we should consider is government policy. Government policy in the sense that governments have to be a lot flexible around the policy they're making to guide around to have a successful PPP. Because without the flexibility and the trust of government in not changing the goalpost in the middle of the match, that will drive home, a very successful PPP. Thank you.
Okay. Can you hear me? Okay. So for me, when you ask that question, you also have to go back to what a PPP is, public-private partnership. So it's a meeting of the minds between the private sector and the public sector. So when you want to think about what makes it successful, you have to think about the expectations that both parties are bringing to the table. So for instance, you've got private sector bringing its capital, public sector bringing what it brings typically, which is regulation and policies. But when they come to the table, you have to ask yourself, what is the business case? What exactly is the need that I am solving for? And from there, you begin to work out the expectations, the reasonable expectations of both parties. So in this instance, when you talk about health, government wants hospitals, government wants access to good, credible, effective healthcare for its citizens. Private sector, obviously, is going into it for a commercial purpose, so they want a return on their investment. So you need to have a situation where both parties can reasonably meet their expectations, but in a clear, transparent, and trustworthy environment. So when you say what is necessary for a successful public-private partnership, both parties coming to the table, understanding what they're solving for, understanding their reasonable expectations, and both parties knowing that they're going to meet those expectations in a non-exploitative manner. So trust, transparency, and reasonable expectations.
Thank you very much. Good morning, everybody. So I'm going to borrow a leaf from what my co-panelists said, and I'm just going to say goal congruence. So when you come to the table as the private party and the public party, you have to be reasonably assured that both of you are actually trying to achieve the same goal. And from there, you are now able to, dovetail into trust, transparency, and everything else. I also think that in terms of public-private partnerships, you have to think about what competencies each partner has, each party has. Like, what is this person good at? What can this person bring to the table? So, for example, at NSI, where I work, we're always talking to the government and saying, we don't necessarily need a tax incentive for us to invest. But if you as government can create the market and pull the market and assure us of revenue, we would invest. So it's just looking at different, like, what exactly can you bring to the table and what can you bring to the table that is most suited to achieve one common goal. Thank you.
Thank you. Unless you want me to repeat what the co-panelists have said.
Okay,
Do you want to move to the next question?
So, that means you practically agree to.
Thank you so much. Just like Lola said, they've actually said everything. And I think the most important thing, which Toyosi has actually set the ground for this morning, is the regulatory and legal framework. Because a lot of this partnership, if it's not well consumed, actually leads to disputes and a lot of things. So the main thing that we should start to look at is what are the regulatory and legal framework that guide PPP at all levels. Thank you.
Thank you very much. So back to Mrs. Bukola. So what from your experience so far, what are the challenges and opportunities that the Office of the PPP encounters when structuring healthcare PPP agreements to incentivize innovation and expand access to quality healthcare services, particularly in underserved areas?
Okay, that is a very loaded question. So let me try to unbundle it. So let me first of all talk about challenges, and I mean challenges from our own perspective as government. Everybody looks at government as, oh, you must be able to solve all of the myriad of problems that we have. But the thing is, government should be an enabler. Government is not there to employ everybody that needs a job, but government should create the right enabling environment that allows businesses to thrive, whereby they're able to become employers of labor. That's on the one hand. But in terms of challenges that we face, I think for me it would be unreasonable expectations. And I say this, with all due respect to the private sector, because obviously I came from the private sector to government. What I've seen is a lot of people come to government thinking government is stupid.
Wow.
They say government is stupid and we're going to pull the wool over their eyes. Obviously, private sector wants to make money. You're not Father Christmas. You're not Santa Claus. You're not coming there to dole out cash. But you also want a situation where you're bringing something to the table in as much as government is also bringing something to the table. So I've seen situations, and I'm currently, negotiating 2 separate health PPPs at the moment where they ask for unreasonable things. And I ask myself, if you were government, you wouldn't accept this. Why do you think as government I should accept this? So they don't want to negotiate. They want to direct. They want to tell you what they want. I know you're bringing your capital, but it's a partnership, and it's a partnership that will endure for years. So if I'm stupid enough to grant you all of these unreasonable requests, obviously my successor in office will come and unravel it. And it casts aspersions on my own character. No, on my character for acquiescing to all of these unreasonable requests. So one of the things that I always ask private sectors, when you come to the table, come with reasonable expectations that makes it possible for your contracts to stand the test of time, so that, in future, nobody is looking to unravel the contract and say, oh, this looks very sketchy, There's a clear business case that has been made. It has been properly negotiated. The revenue sharing model between government and private sector has been adequately interrogated and also independently. But most times they want to tell you what they're going to get. They no longer want you to interrogate financial models. They come and tell you, this is what government will get, this is what we will get. We want 50 years. We want our C of O on day one. I mean, there's so many unreasonable things, and what I try to explain to them is government is not stupid. We're a custodian of the commonwealth of the people. So if I'm stupid enough to grant all of these unreasonable requests, either which way, we're all going to pay for it because it's taxpayers' money at the end of the day. So those are challenges. Now, in terms of innovation, I'm actually very happy to say that we have an existing health PPP that was signed last year, which is called the Smart Health Information Platform. Now, what that does is to help us to aggregate all of the health information relating to everybody in Lagos State. I know people would talk about privacy laws and all of that, but this is obviously done with regards to existing and comprehensive data protection laws in Nigeria. So what it does is to digitize all the information so that you can move easily across from government hospitals to private hospitals without the need to carry physical files around. Now, if that is not innovation, tell me what is, because for so long we have been bogged down by, you get to this hospital, let's just use the government hospitals for instance, you go to a general hospital in Ojo, or they have to transfer you to Lasut, they get there, you have to buy a file, you have to, start getting all of your documentation with the Smart Health Information Platform, with a token provided, because with the privacy laws that I talked about, nobody can access your information without you being aware. So once you go to the hospital, you have to generate the code to give to the healthcare practitioner for them to access your information. So obviously you're aware that somebody is accessing your information and they can see all of your diagnostics, your lab results, your previous prescriptions, everything is on there. So it allows people to access care in a very responsible but also innovative manner. And that is something that we signed last year in partnership with InterSwitch and Eclat Health Services.
Yes, thank you very much, Ms. Bukola. That was a very comprehensive run-through of the question. So, to Dr. Adeyemi, I'd like you to let us know how HMOs like Avon effectively collaborate within PPP frameworks to expand healthcare coverage and access, especially for underserved populations. And if you have prior projects that you've implemented and then you've generated evidence to show that this works, you can share with us. Thank you very much.
Thank you very much. So, first of all, one of the things that will drive search forward for, especially where we call them the rural areas or on, areas where we collaborate with the government to have a PPP on this, is number one, we have to invest on technology. We know that it's not everybody in the rural dwellers who have smartphones, so we leverage on USSD. And like Ms. Bukola rightfully said, the first platform is creating this innovation from Lagos State, if it could spread across, where you can easily access people's medical records. However, we need to also stem it down, because like I said, people don't have smartphones in those rural dwellers, and they will definitely have to make do with USSDs, just simple SMSs on your phone. And of course, with the advent of technology as well, mobile technology such as telemedicine that we can take to those places, so to avoid congestion or distances from healthcare facilities. So even if it's primary services, we can easily they can easily have access to primary services by having telemedicine taken to them, mobile telemedicine, that is. So those are the kind of things we should look at. However, one of the things that we should also fundamentally remember is that even these healthcare facilities don't have adequate mechanism in place, such as computers and what have you. And if we're going to be using these electronic records, like she's mentioned, we have to first put those things also on ground to be able to, adequately give the people in the rural areas access to at least quality healthcare from the primary services as well. For Avon HMO, what we do currently is that we also collaborate with government in creating, an affordable, cheaper plans, yes, healthcare plans for the rural dwellers, so nobody is disenfranchised. And we take it to the communities and have that, done. And likewise, because we're very big on wellness and preventive medicine. So we also ensure that we collaborate with the community heads and even the government of those communities to educate people on how to, have their preventive medicine done in order not to spend so much, because that would be penny wise pound foolish if you have to treat illnesses after, when you can actually prevent them with less amounts or less resources. So those are the kind of things we are also very big on, and we take it out and far wide. Thank you.
All right, so generally, I was in the rural areas.
So the optic has been very welcome, very, very welcome. One of the things that I also, personally witnessed last year was when we went to rural communities to educate, especially the young growing women, about their, menstrual cycle, and having to donate a lot of reusable sanitary pads to them as well across communities, and having them to prevent themselves from, catching diseases or, unhygienic practices. So optic has been very welcome, and we are always, well received in those communities when we go out to them.
Thank you very much. So I'd like to engage Lola.
Okay. I feel like everyone has answered, especially Bukola and Funke. Honestly, in my opinion, of all the points that were brought up, I would say trust is very, very critical. Trust between the public partner and the private partner. PPPs, I liken them to relationships and marriages. That is really what it is. It is a long-term relationship. There is an end, but it is long-term. As one of my co-panelists said, 30 years, 50 years, just to give you an idea. So trust was one major thing that I had to learn personally. And so the government is increasingly aware that they cannot fund all the sectors. They can't develop all the sectors. And so they need to work hand in hand with private partners to achieve similar goals. So alignment, as Funke mentioned. So that is well known. We have to enter agreement. Then the trust. How do we trust each other? I don't know who Bukola is working with, but I would never see public sector stupid. Everybody has their strengths. We just work very, very differently. And so you have to trust in your partner's strengths and come to an understanding of how to make it work vis-a-vis, your strengths and your weaknesses. Now, understanding that you need to partner does not immediately and automatically translate into trust. You actually have to build it. How I solved that problem, it wasn't really a problem, but you had to really start from the get-go. And how we started from the get-go was being honest. Being very, very honest with what we were bringing to the table. And also asking the right questions to ensure that we were understanding what the other party was also bringing to the table. So we had to be very, very honest down to the fine print. Everything, every single thing. And what we did was we built systems and structures to support that transparency and the communication that we wanted to nurture with our partner. Emails, reports, this is how much we made, this is our cost, this is how, everything down to the fine print, labor, capital, equipment, all of that. So that was one critical thing. And on top of that, I would say is the cultural difference. There is a cultural difference, and I've experienced cultural shock personally. Private sector, we tend to move fast, quick. We make decisions on the go. One phone call, one email, boom, we're done. Public sector, their system is a lot more stricter. It's quite strict, and as such, it can be lengthy. So their system is different. Now, no one's perfect. We have our strengths and we have our weaknesses, right? You have to understand that. And you have to understand that cultural shock if you're going to make it work, if you want it to be successful. And listen, that cultural shock can be as little as calling a government official by their wrong salutation. So you see, I said call me Lola because for me it's just Lola, but I have mediated a very lengthy, official, formal, I can't remember what they called it, resolution something something. I was so shocked because one staff he had referred a government official by their first name. Now, for me, in private sector, it's fine. What's going on? No, they reported. They reported the staff. So you also have to understand that cultural difference. If you're going to make it work, understand your partner, understand how they work, down to how they want to be referred, and you have to be ready to cooperate. Whatever, imagine you're in a relationship or in a marriage, right? You have to understand each other, you have to trust each other, you have to learn about each other's, way of life and modus operandi, and then you adjust if you want it to work. So for me, it has been trust, the cultural difference, and then building system and structures to support that. Thank you.
Wow, thank you very much. That was... That's a very
You can just call me Funke.
All right, okay. So, okay, you work with the NSIA, right?
Yes.
And NSIA, I mean, the major founders, or let me say founders of the NSIA Cancer Center.
Yes.
All right. So, I mean, given your NSIA's role in strategic investment, what innovative funding and investment models do you believe are the most viable for healthcare PPPs, particularly in Nigeria? And particularly in Nigeria, because we have diverse funding mechanisms and models. Which one have you seen that has worked from your experience through NSI in Nigeria? All right. Oh, sorry. Let me take the question again so people can hear. Everyone. So I just asked that given Funke's NSI's role, right, and in strategic investments, what innovative funding and investment models does she believe would work or are the most viable for healthcare PPPs in Nigeria specifically? You can go ahead.
Okay, thank you very much. So let me just give a brief about NSIA. It's the Nigerian Sovereign Investment Authority. A lot of people think that we are private, but we're not. We're a public institution set up by an act of parliament, owned by the federal government, state governments, and local governments, which basically means that all of you here, have a piece of us. But also, it's very validating that you're calling us to talk about public-private partnerships and you want us to talk about it from a private sector perspective, because we've always tried to operate with, a private sector ethos and lens. So I think there are two things I'm going to say in terms of the financing mechanisms that I've seen that could potentially work for, and that we have tried that could work for healthcare infrastructure. And I don't think they are innovative, really. I think it's what everybody intuitively knows, and it's just about execution. So the first thing is blended financing. And blended financing can come in different ways. It can be, instead of giving traditional debt with a high interest rate, it can be a blend of equity and debt so that the capital is more patient. It can be like first loss capital, for example, where you're exposing yourself to the risks, of taking on the risks of any loss. It can be blended with development partners so that you're able to offer technical assistance or you're able to offer grants alongside the capital that you're providing, and that can reduce, the returns that are expected to come back to the investor. It can also be things like in-kind assistance, technical assistance, where you're not actually getting money, but they're taking off something from you. The second thing, which I think has been really relatively unexplored, and I kind of alluded to when I was answering your earlier question, is really if, the government is looking to be able to provide healthcare access to the population, investors are looking for the same thing and want to deploy capital to provide healthcare infrastructure. Perhaps the best thing will be for healthcare, private sector to focus on supply of healthcare infrastructure and rely on government to focus on demand for the services that will be provided by the healthcare infrastructure. So if we could get government in some way, and it doesn't have to be insurance, I know we always talk about insurance and all that, but if we could get government to say, you know what, I'm going to procure the services that come out of this healthcare infrastructure, you would see a lot of private sector capital move towards ensuring that there is supply. Unfortunately, the way the healthcare system is financed right now is mostly that we're paying for inputs, we're paying for processes, and we're not really paying for outcomes, and that needs to really undergo a major shift. Thank you.
All right. Thank you very much, Funke, for that. I'd like to hear from Mr. Femi, because I know, Mr. Femi, you work with the Healthcare Federation of Nigeria, right? And it represents healthcare stakeholders, right?
Yes, please.
All right. Recently, HFN can effectively facilitate collaboration between various private sector entities and government bodies to identify priority areas for people that can genuinely drive innovation and access across the different tiers of healthcare.
All right. Thank you so much, Dewumi. There are a lot of things that has been said here today, and I'm so delighted to have this panelist here because they are cutting across a lot of things that are going to be discussed or that you need to understand. One of the things that we are trying to do in the country, especially, is to create access for people to get healthcare services. When we talk about access, a lot of people mistake it for proximity. And one of the things that I want us to understand here today is that access is not just about proximity. Access actually involves these innovative ideas that we're talking about here today, because that actually galvanizes a lot of things. For us in Healthcare Federation of Nigeria, like you mentioned, we are just a collaboration of healthcare providers. And one of the things that we are trying to do is to align the private sector with government policies. And I think Bukola has said some things about that also. I've been lucky. I've worked in the public sector. I've worked in the private sector, so I have a blend of the two lives, and that is one of the things that HFN is trying to do. So one of the things that we are trying to do now, like Lola said, I will go back to that marriage issue, because if you actually want to meet somebody, you need to create an avenue or a platform for them to be able to interact. And one of the things that we are doing in HFN is to institutionalize strategic collaboration forums for us to be able to matchmake between the private sector and the public sector. And one of that is our annual conference, and also what we call the leadership conference. The leadership conference, we bring a lot of people together. We bring legislators, we bring the private sector players, we bring the regulators. So everybody sits at a table and they meet to discuss what is on ground. So for us in HFN, one of the most important things also is to align with national priorities. There are a lot of national priorities, and that's why I like when Bukola, I think, was talking about government not being stupid. There are a lot of things that government wants for the people. These are public goods. These are things that they believe the public needs. Maybe they are not aligning it well with what the expectations on the other side is, but these ideas are not stupid. PVAC is there. NSIA, I'm happy that Funke is here. NSIA is there. And one of the biggest partnerships that you can even mention in Nigeria today is that NLCC, that's the NSIA Youth Cancer Center. That's one of the biggest oncology centers in Nigeria, and it was developed through a PPP. The Basic Healthcare Provision Fund, which is something that I'm sure Yvonne is also interested in, is a government initiative. But how do we align the private sector with all these initiatives? I've talked about access, and I've said it's not just about proximity. Sometimes we need to digitalize this, and that is our aim in the Healthcare Federation of Nigeria. We have tried as much as possible to stratify the levels of intervention. If you look at the level of care in Nigeria, you see the primary health care, you see the secondary health care, you see the tertiary health care. What does the primary health care need? A lot of people need access to these facilities at that level. How can we get those services to them without building brick and mortar? Everybody wants to renovate a primary health care center and things like that. So what we are looking at is creating digital hubs. I see the mix of people here today, and they are young people. And I want to believe that we have a lot of techies here. You are needed, but you need, like a lot of the speakers have said, you need an enabling environment to be able to operate within the private and the public sector. So those digital innovation hubs are things that we are looking at also. And at the end of the day also, whatever we are planning in Nigeria is not peculiar to only Nigeria. A lot of countries have done it. You've had examples here of Rwanda today. You've had examples of Kenya, how they've been able to do tax-free season for like 6 years for some people, and some other innovative things. So global partnership also is one of the things that we are looking at. And when you are talking about global partnership, PPP comes into it also, because the global person will not come into Nigeria and thinking that it can operate without the laws of the country. So these enabling laws is one of the things that is also paramount. So regulatory framework must also be there to be able to define clear standards and how everybody is supposed to operate. I need to trust you. You need to bring everything to the table. Lola has said it. Everything I was doing, I put it on the table. Even up to capital, even up to minor expenses, everybody needs to see it. The private side needs to see it. The government also needs to see it. And that is what brings trust amongst us, especially in PPP. Thank you.
Thank you very much, Mr. Femi. For me, one of the key points that you mentioned is actually alignment with national priorities, because I mean, it's very possible to have a range of possible healthcare partnerships, right? But if they do not align with the national priorities, it would most likely not be viable. So, and I think that would be, so Ms. Bukola, that is what your office does, right? Your office sort of kind of categorizes and prioritizes partnerships that are aligned with national priorities, right?
Absolutely, but also in Lagos State, we also have a master plan for each sector.
Right.
So you've got the transport master plan, you've got the health master plan, and these are master plans that have been in effect since the time of our now president, and it's been refined, tweaked, adjusted, and added on to, since 1999. So we also have a Lagos State Development Plan 2052, which was amended and relaunched in 2022. So it's forward looking to 2052, and within that you have what we hope to do within key sectors, and everything ultimately ties back to a human capital development index, which is priorities on health and education, because an educated population portends great things for your further economic growth and development. So is a healthy population and a well-educated, population as well. They're ready for the jobs of the future. So there's been intentional budgeting and prioritization for both sectors. So in terms of that, I want to believe that we also have that at the national level, but everyone talks about the fact that Lagos State is a country within a country. So at the end of the day, we've been very focused on ensuring that we can get, the greatest good for the greatest number in Lagos State, because every single tribe in Nigeria is represented here in Lagos State. It is a melting pot. So.
Hey, good. Yeah, so I would like to know, and I'm sure everyone here too would love to know, from the already implemented healthcare PPP projects, what were the elements that worked out in the partnership? How are those partnerships doing so far?
Okay, let me start from the second part of the question. So how the partnerships, so some have been quite successful, some have not been as successful as we would have liked. And, this is also going back to what I said earlier about, private sector always wanted to pull the wool over, government. So I don't mean that they come to the table saying, oh, you as government, you're stupid. What I mean is they're less than, upfront. So we have a situation, with some of our health PPPs where they keep telling us, it is not profitable. This business is not profitable. We are making a loss. How do you finance people call it? It is a loss leader or something. This business is... And I say to them, okay, let's cancel the concession. Oh, no. We will continue to manage. But I am not getting anything as Lagos State, you understand? It's supposed to be, a revenue sharing model. But, they say, no, we are not. The cost of the reagents. It is prohibitively expensive. We're not making anything. But I haven't seen any revenue for the last 3 years. But somehow or the other, you don't want. So I said, you know what, let's cancel it. Let us restructure it so that it can become profitable for you and government. No, don't let us. Let's just continue and manage it to get better. So those are the kind of things, I see. And I say to them, and sometimes it's very forceful. And one I just recently threw open again, I had to do an EOI and say, you know what, we need to bring more people into the space. Because when we bring more people, it reflects the economic realities. We can go back to the negotiating table and say, this is actually what obtains in the market. So if the cost of your reagents, the cost of your disposables are actually quite prohibitively expensive, we will see it and we will adjust accordingly. So government will adjust its own expectations in terms of the revenue it hopes to get. And at the same time, you also make a profit. So it's been, an arduous task trying to get us to that point. But we're at the point where we are actually, about to, sign brand new concessions in that area. So in terms of successful PPPs, in the health sector, I would say the one for mortuary services, that has been quite successful. And case in point, I think a couple years back, I wasn't back in Nigeria then, but I understood that around the Ikeja area, you could smell like the from Ikeja General Hospital, I think you could smell the stench of dead bodies because they were just thrown there. They didn't have adequate refrigeration services for dead bodies. But since the time that we actually executed, a PPP with TOS funerals, the way and manner in which our dead bodies in Lagos State are handled, kept, and then eventually, transported to their final resting place, I have to say it's one for the history books because, they're treated with dignity. Refrigeration services are the best in the country, I dare say. We don't have the instances where, dead bodies are treated in, a less than desirable fashion like you used to have. So that is one of our most successful, health PPPs, and they have been with us, I think, for the last 15 years now. Yes.
Wow. So have you at any point had to cancel out a partner on a PPP for whatever reason? What do you think the usual reasons?
So we haven't cancelled. We've done amendments to existing concessions, but we haven't cancelled because, sanctity of contract is also something you want to protect because it signposts to the investor that this is not a credible contracting party when you come into the mix and you cancel our concessions. What you would want to do is to bring them back to the table to renegotiate, to re-amend. But the ones that we've actually had to, throw out EOIs was they had expired. But they were trying to continue on the same terms. It's not profitable terms, is what I call it. So it had expired, and we said, you know what? Rather than just continuing on, a month-to-month, arrangement, we're going to throw open an EOI because those concessions had naturally come to an end. You want your investing public to see that you, as a subnational, you are truthful and you're responsible with respect to your obligations. So if I give someone a concession for 20 years and in year 2 I cancel it, people would not approach Lagos State, to partner with them because they would say to, my financiers will probably not want to give me any money because they say Lagos State is in the habit of canceling concessions, so we don't do that.
Mic to Ra. Yes, so.
What are your thoughts about investments in green technology, and how do you think these investments will actually sort of enhance our healthcare resilience in Nigeria? Because we know that green technology and sustainable energy is actually a very global topic currently. Right? So if we were to bring that into the healthcare sector in Nigeria, do you think they would enhance the healthcare resilience of the country?
I'll start by giving a story. I always like to be practical with my answers. A few years ago at our PPP center, and our PPP is an ICU and a surgical center, FYI, we had 4 patients on the ventilator. And like 2 days later, I got a call saying, Ma, we've been on Geno for 3 days. I said, okay. Interesting. What happened? And they cut the lights. They cut the lights, as in the lights, the cable broke. What happened? He said, no, NEPA came, they cut the lights, Someone did not pay a bill, right? And it's fine, because it happens. It's expensive to run these government hospitals. They're huge. And they had not had light for a few days. Then the following day, he called me to say, Ma, the generator broke down. I said, generator, how many patients are on the ventilator? 4. And generator is not working, as per there's no lights. We had only 4 hours. So the ventilator have the backup battery 4 hours, and then the UPS would buy us another 30 minutes. I was speaking in every tongues that the Holy Spirit understands, that the technician would come and do everything that he needs to do on the generator within 4.5 hours. And thankfully, that is what happened. Now, a year before this happened, I had read in the papers about another government hospital where there was no light, a patient needed dialysis and had to travel to another state. And so in the course of that journey, the patient died. I read that story and I said, oh, please, can't be true. Which journalist is this? They're just cooking up stories at this point. And then that happened to me, almost happened to me. I was scared, and I was quite frankly mortified. And what that obviously translated to was solar. Within a week, we had 40 kVA solar installed that could power all 10 ventilators, as well as the theater, and more, because we wanted to give room for growth. By the way, that cutting light thing has happened multiple times since then. So whether the question of is there a synergy between green energy solutions and healthcare is, I mean, I think I've answered that question for you. It is pretty much a life or death question. Solar-powered vaccine fridges, for example, is a matter of life and death in some rural, off-grid, underserved areas for the kids, for children. Solar-powered mobile clinics can help you scale screenings, treatments, and whatnot in off-grid areas. I've been to some primary health care centers where you wouldn't even want to step in, not to talk of injection and whatnot. There's no lights. They've not had lights for days, weeks. So the synergy, the question of if there's a synergy is, I mean, I think we all know that. There is a direct and urgent correlation between green energy solutions and health equity.
Right, thank you very much for that story. Thank you very much. And I'm sure we've come across in several news outlets about instances where, I mean, especially in public hospitals, where there was power outage and then ICUs went down, and then, I mean, and the number of people died. And I could also remember in last week, when I was studying there in my final year in 2023, I mean, we had power, we didn't have power supply for months. And then I know that the pediatric ICU section of the hospital were running on generator throughout. And aside from the noise that the generator was even causing and then the carbon monoxide production, it was very risky. For me, I saw that it was very risky because if this generator packs up, right, to get another generator or to get the technician, I mean, time would go, and then at the end of the day, we are just sort of, in quotes, gambling with people's lives. So I think that public hospitals or private and public healthcare centers, the moment you say that you have very critical services that you are offering, it's just best to have some sort of investment towards green technology, right? Just so that you can safeguard the critical services that will definitely need them. Yeah, so in just one or 2 minutes, I would just like Dr. Adeyemi to let us know from an HMO's perspective, how can PPPs enhance quality and scope of healthcare services offered to enrollees, right? And particularly in leveraging technology and innovative service delivery.
All right, thank you. So in doing that, the HMOs have to leverage on technology. And currently, because at the end of the day, what you're looking at is the clinical outcomes and the best enrollee experience at the facilities. So if you're going to be leveraging technology, one of the things Avon HMO is big on is AI. We are very big on technology, and we've gone to the level whereby we try to be as transparent and skilled up to the optimum level, whereby patient experience is priority on our desk. So, for example, you get to the hospital, there's hospital delay in approvals and what have you. We've gone past that level where you're getting manual approvals. And even for the experience of the partner hospitals, which is the bane of contention, is usually, oh, you're owing me, you've not paid me, or you're delay payment. We've also scaled through that because as it is today, from Avon HMO, we will pay you at most 3 days. 3 working days, you get your payment. So this is leveraging on technology. And then for the enrollees as well, especially in the rural areas, like I mentioned earlier, mobile technologies whereby we can do telemedicine. And of course, we also look at how we can, apart from using technology, what's it called? Payments platform like your mobile app and what have you. We focus largely on USSD. And of course, capitation plans are also what we've developed within ourselves, so that it's not eroding, quality healthcare. Nobody is undeserving of that. So quality healthcare, you're getting quality healthcare, and of course at an affordable price, and not having to swindle between the providers and yourselves in terms of negotiation of prices. You're able to tie it down in terms of capitation. So these are things we currently do to ensure that it comes out successfully. Thank you.
All right, thank you very much. Also, Funke, in 1 to 2 minutes, what are the key lessons and success factors from the NSI's Lutz Cancer project, right, that you believe are crucial for replicating similar facilities? And also, does the NSIA intend to invest in other disease areas or in other wellness areas aside from the cancer center? Thank you.
Okay, thank you. I think in terms of like the key success factor for NLCC specifically, which has changed its name to MedServ Youth Cancer Center, by the way. Yes. What I would say is that in terms of working with, and the fact that we were also public sector, had an advantage. We had an advantage in working with Luth in setting up NLCC or MLCC, but it wasn't smooth sailing. And in fact, let me also try to, do what Lola did and tell a story. We were also in the position that Bukola talked about, although we were the people saying we weren't making any money, because we weren't. And because suddenly in 2023, maintenance fees we have linear accelerators in there. Those machines are $1.6 million at least each. And we pay maintenance fees benchmarked to the dollar. And it was like, okay, there's nothing coming from this your project that you have put inside our space, and you took over our whole radiotherapy center, and there's no money coming out of there. But I guess because there was some level of trust coming from the fact that we had signed something with the Federal Ministry of Health, which is the regulator and the policymaker for tertiary healthcare services, we're also public sector, we're able to come back and renegotiate, which is kind of like what you were pushing for, but we came back to the table and we renegotiated, and we said, you know what, if you are waiting to be paid off profit, it's never going to happen. So can we look at some kind of leasehold fees that we can give to you, for rent? So it's flexibility, being able to come back to the table and just, going back to the marriage example, just trusting that everybody is just trying to do what is best for them, but you still have one goal in mind. In terms of whether NSIA is going to go into other disease areas, I think one of the first things that we realized is that we have limited capital, just as everybody does, and we can't be everything to everybody. So we had already determined that we were going to have specialized areas, and it was going to be diagnostic services. We also have projects in Kano and Uma here, and it was going to be single tertiary services. And so we started with oncology, and we're very intentional in how we invest. We do a proof of concept. When we see that we can scale it, then we scale. So we're currently scaling to 10 more diagnostic centers, 3 more oncology centers, and we're focusing on going deep in oncology and diagnostics as opposed to going wide. And to put on our public hat, what we've now started to do is look at the entire oncology ecosystem and thinking about the clinicians, the oncologists, the radiotherapists, the physicians, the oncology nurses, the oncology pharmacists you need. And we've been holding oncology summits where we bring together regulators, accreditors, civil service to think about how we can professionalize those specializations. And I don't know how many of you saw in the news last week that 3 new cancer centers were commissioned by the federal government in Benin, Katsina, and Enugu. NLCC, or rather NSIA, project managed the execution of those cancer centers. So, we're just trying to build ourselves as a known name in oncology and diagnostics, and rather than spreading ourselves too thin. Yeah, thank you.
Yes, thank you very much. I think that's a very, very key statement. It's like going deeper rather than wider. It's actually very critical. All right. Also from Mr. Femi, in 1 to 2 minutes, what are the policy advocacy efforts HFN is currently undertaking to create a more enabling environment for healthcare PPPs?
All right. Thank you. I will just take it from where Funke stopped, because you actually saw a lot of things that Funke has mentioned now, except I'm wrong. You actually see that a lot of them are not public-private. A lot of them are actually public-public. So one of the things that we do in HFN is to make sure that the private people also participate in all these, let me call it largesse. Because if you can imagine how much money was spent on the NLCC project, and then we have a lot of centers that are in Nigeria that can actually do what Luth is also doing. I'm sure Lakeshore somewhere is here. The likes of Marcel Ruth is available and other facilities like that. If that kind of investment can actually come into the private sector player hands also, it goes a long way. Funke mentioned something, and she has said it succinctly 2 times. She said, we are not, people think we are private, but we are not private, we are public. So there's a difference sometimes between the public and the private. As good as the public is, a lot of people always believe there is more efficiency in the private sector. And that efficiency is what we want to bring into partnership. So one of the things that we are doing in HFN is to make sure that we are there when they are formulating these policies. At our last leadership conference, one of the people that we brought in strategically was the Controller General of Customs. Because one of the things that is plaguing this country is APIs. A lot of manufacturers are produced in the pharmaceutical industries, and the active ingredients they are using, the tax they pay at the airport at the port is something else. And we were able to discuss with the Controller General, and this year, luckily, they've considered to it. So for APIs coming into the country now for pharmaceutical industry is 0 tax. So these are the things that we are trying to put ourselves in their faces. There are a lot of things that we are doing. We have a Lagos State and Yobe State in the whole of the country. Happens to be the only 2 states that have a regulatory agency for healthcare facilities. And this actually breeds standards and quality. So what we are trying to do now is to create a national health regulatory agency which is going to regulate all agencies, and this actually guarantees NICRAT is doing a lot of things. I'm not sure whether a lot of people here know. There's a fund that has been seeded through NICRAT to what we call a National Cancer Health Fund. To date, we have about 4,000 plus applications. 1,600 people have been treated across the 6 geopolitical zones. Coincidentally, all the hospitals are public hospitals. So that's one of the things that we are fighting for now, that these funds should actually come down also to the private sector players. And you see, there's a lot that we need to do, especially in this space when it comes to public-private partnership. Lagos State is doing a lot, and I want to commend them. The health information platform that they are building cuts across so many things, and we are working with them also in so many areas. There's an emergency side of it also, which is also critical. And I think the emergency side of it also, we are working with them to be able to create private people that can actually help in emergency services from the state level to the national level. Thank you so much.
All right, thank you very much, Mr. Femi. So, can I have 2 questions from the audience, please? 2, very quickly. All right. Okay, one from you and one from you. All right. Please, please very quickly make your questions brief and concise as much as possible. No, wait.
My name is Ridwan, medical doctor. Thank you very much for your time, panelists. It's been actually amazing. My question is to the people from the public side. That's Madam Funke and Madam Bukola. So basically, my question is, thank you for everything you've said. So what I want to also encourage the government, the public side to be more transparent. So the private sector needs to know what they want to work on. So there's a lot of opacity when it comes to data. For example, like Lagos State now, if an emergency should happen now, I don't know the nearest healthcare facility near me. So, and I sent a message to a farmer back then. I release your data. Let's know how many facilities are in Lagos. You regulate this thing. Just release data and let boys, create an Uber-like app for you and just make this thing accessible. I've sent a mail. I've spoken with the PR. I went to the office. Said, write a letter. I'm like, don't make this thing too difficult. Let us know the problems. You definitely, we've gone beyond criticism. Give us the data. So that's for the. Then also, I also want to speak to the NSI. You run this 220,000 fund every year. and I'm sorry, not every year, 310,000 innovation, the MPI, the prize innovations. I want to speak specifically for the healthcare part. See, healthcare is difficult. That's just the truth. It's difficult. So, you're talking about returns, like, healthcare is difficult. The government does not promise more banks during campaign. They promise more hospitals. So, there's a lot of issues with healthcare. So, I want the government to align your incentives. Also, Lagos State do the LSCTF. State your problem. Don't say any innovative idea. I have this problem. Who can fix it? Don't whoever has an innovative health. I have issue with health insurance adoption. I want healthcare startups that come and fix this issue for me. It's fixed. I have for the Lagos State too. Okay, I have this problem. Stop making, because healthcare is a lot of work. It's difficult. It's long, hard work. So you want people that are coming. I'm not giving you money because your idea is fine or you have a nice pitch deck. I have this problem. I'm trying to work on this. So for example, now looking with for the Lagos State now. So the way it works is I was a doctor in General Hospital, Alimosho. A patient comes in. I don't have bed space. I can manage. I don't have bed space. I have to refer. I'm obliged to refer to the next general hospital. It doesn't make any sense. I have private hospitals around me that have empty bed space. Like I just take this patient. If they want to, there's autonomy. But I can't even put it on my referral. Go to from Alimosho. Go to either Isolo or Agege. And it's stroke. I don't know if they have. I'll be stroking it. You go here. It doesn't make any sense. So these are just state your. These are don't make the data like show us the problem and give us the data. We'll work on it. We've gone beyond criticism. So thank you very much.
All right. Thank you very much, Dr. Ridwan. That was a very good suggestion because I've also had my fair share of experience around the same problems you just mentioned. All right. Next person.
Good morning, panelists. So my question, I'm actually a legal practitioner, yes. And so I'm coming from the legal and regulatory aspect. And I heard Madam Bukola speak of tax incentives, and then she said that tax incentives are not in themselves enough incentive to the very extent where there is a market available. And I do understand that. But my question is, and I just want to get your opinion on this, if you were to, Madam Funke, yes. Sorry, I mixed the names. Yes, Madam Funke. No, Madam Funke, yes. So, all right. So I just wanted to know that in the instance where, because for developed countries, yes, we see that they have a very comprehensive tax system, and their tax rates actually are higher than developing countries. It's a whole lot higher, but then we still see we don't get so much complaints as we would have for members in citizens in developing countries. So my question is, like when it comes to investments, holistically, would you prefer a highly regulated or a highly regulated market and environment with enough markets, but then high tax rates, or you'd prefer an averagely, in terms of an average-like regulatory system or condition with a large market and then like a lot of tax incentives? Which would you prefer in that case? And then secondly, my question to Madam Lola, I'm also Lola too as well. So, hi. So the question is, you spoke about cultural differences, and I would like to know, right, are there instances where these cultural differences, they've been amplified over efficiency, and in what manner have you been able to resolve them? And I'm saying this from a professional angle because these things also come up day to day. Then finally, for Madam Bukola, and on, okay, yes. Now this is also for you both, right? On the public-private partnership. And then, I think Madam Funke also spoke on blended finance, but also I would also like to get your opinion as well. And then she spoke about equity and funds. Now, I'd like to get your reaction as to, because I've worked on a deal where it was everything was set. And then the government was now like, they wanted more stakes. And it became a bit problematic because the client came back and we then started looking for ways to dilute the shares. So I would like to get, of course, not everybody, something that really resonated on this panel was trust. So I would like to get what exactly would be the reaction, or in what manner do we get to, because the private guys whom we did represent, they were like, what do we do now? because they're already halfway gone when all of this happened. So I'd like to get what counsel do we, members of the public sector in this regard. So yeah, thank you.
I'm sorry, one question, 1 minute. One question, thank you. My apologies.
Okay. Good afternoon, everyone. Or good morning, still morning. My name is Dr. Rosette Oti. So I'm going to be speaking as a new doctor. Just like Mrs. Odoye has said, I think Lagos State is way ahead in things like this. For someone who trained in Calabar and stayed in Calabar for most of her life, when I hear things like this, it feels like so much information, and it feels like just making castles in the air for certain states. So my question is actually to you, sir, about the HFN. Is it compulsory? Are you always on every PPP table? Because I think for many states, PPP is usually just political statements. It's just something government just goes into because they want to look like they are working and all of that. And also one thing I would like to say is that I think PPPs are designed for patients, but we actually do not consider patients at this table. We do not consider cultural beliefs. We do not consider the barriers to why they are not even seeking the care that is already available. And also about the cancer fund. I remember when someone mentioned it on Twitter, I was like, oh my God, everybody, most people were surprised. So my question is, why are these information not out there? Why do people not know about these things? And is the HFN, are you mandated to be at every negotiation table to ensure that this side gets a good deal, this side gets a good deal, and my patients get a good deal? Thank you very much.
All right, so I would like to give all speakers 1 minute each to respond to all questions. And
let me just start from the last speaker in a very short response. What we try to do is that we are not mandated to be on every panel. But because we protect the interest of the private sector, we follow these policies. And any policy that is of interest to the private sector, we try as much as possible to get ourselves on the table. We were at the forefront of creating NICRAT, that's the National Institute of Cancer Research and Treatment, which led to the creation of this NCHF. But when the implementation started, like I said, it started with the public hospitals. And we had to go. In fact, yesterday we were there. If you check our LinkedIn page, you will actually see the pictures there. We were there yesterday to meet the DG of NICRAT. And one of the things that they have said now is that we should go and compile a list of private hospitals that can actually play in that field also. So what we do is like a lobbyist group. When we see that there is a space that needs to be filled by the private sector players, we move in. So we're in discussion with so people have talked about IT here today. We're in discussion with NIDA in terms of data protection, data privacy, and all those things that Toyosi talked about. So, like I said, National Regulatory Agency, we're there. Antimicrobial intervention, we're there. So we try to put ourselves there to protect the interest of the private sector players. We are not operators, and that is why a lot of people trust us. We are not there to benefit, or because we have a pharmaceutical company, or because we have anything. We are just there to protect the interest of the private people. Sector. So what you don't know, I'm sure in a very short time you will start to know. Maybe because you are coming to Calabar. One of the things that we are trying to do in HFN also is that we are trying to move to the regions now. Our next conference is going to be in the South-South. So a lot of people in other regions will actually know about what we are doing and how we can protect their interest.
All right, thank you very much, Mr. Femi. So Lola, just briefly.
Hi Lola.
Thank you.
So your question was around cultural differences and if it can be amplified over efficiency and how to go about this.
Okay, so with cultural differences between the public and private sector, the answer is yes and no. It can amplify efficiency and it can also obstruct efficiency. That difference would always clash. If you wanted to amplify efficiency, you would have to understand that difference, build structure and systems around it, where you are able to really key into the strengths of both partners. I'm really taking my time to answer this question, so I really answer it properly. So, for example, private sector, we're very flexible. We move with speed. We move very, very, very fast. Public sector is there are a lot more protocols. Let me put it that way. That's their structure. A lot more protocols. So in that instance, you can see how it can amplify inefficiency, but it can also amplify efficiency. Like I said, no one is perfect. You have to be open and willing to learn from the other party. For example, before our first PPP center, I did not know who social workers were and what their purpose was in the healthcare ecosystem. I can guarantee you that most private hospitals do not have social workers working within the system. But I was exposed to this in the PPP, and I saw the need for it, especially in an ICU center. Is it the nurse that will be checking vitals and then will go and wash up another patient when it's one-to-one? You know? So that is what really it is about, building systems and structures around that cultural difference. And that flexibility that we have to bring it into the partnership. I've had to meet people after church. I've had to meet people after a mosque. I've had to meet people at the golf course. I've had to meet people at the bar, at the restaurant. You have to be very, very flexible. Just because I'm trying to get you to make the final decision, let's move. So understand what it is that you need, the end goal. Because beyond the politics and beyond the profits is what? The patient's outcome. And both parties understand that, or should understand it. So it's really just about working around it. Now, most PPPs, I don't know about, my co-panelist experience, but with the PPPs where people have come to me for advice that we're breaking down and whatnot, both state, government, and federal, by the time I tore it apart, it was really down to cultural differences and trust. It was really down to it. People were not upfront, they were not honest, and people did not understand the cultural difference. You cannot dare think the government is stupid, act as if the government is stupid, and think you are going to succeed. You will fail. So that cultural difference can either amplify efficiency or obstruct efficiency. Personally, I use it to amplify efficiency. Let me understand what you are doing in the government hospital that I'm not doing in private sector that is working for you that I need to put in, e.g., social workers. And it cuts across every single department.
Thank you. Yes,
Okay.
just briefly, please.
Thank you. The gentleman that talked about the NSIA prize for innovation, I agree with you. We're still scoping exactly what that MPI will be. This is the 3rd edition. The first 2 editions, we saw that we were just seeing people in fintech. We were like, this is not what we want to do. And so this edition, we were like, okay, let's boil it down to health, agri, and education. And for the health, I agree with you. Health is a huge space. And then asking people to actually fill in how much they're earning and how much the business is earning, it filters out a lot of the health applicants, but we're still refining it. We're still retooling. So after this edition, next edition, we'll refine, we'll retool as well. And this edition, we actually did with the Presidential Initiative for Unlocking the Healthcare Value Chain. And, their mandate is in finding healthcare startups is actually more expansive than NSI is on. So hopefully they'll be able to pick up on some of the, good finds and expand on that. To respond to Lola's question, yes, I will take a highly regulated, high tax-paying society to what we currently have. I'm sure you know that Nigeria is one of the least tax-financed communities or countries in the world. And, you know, when I think about tax incentives, I'm like, what's the use of a tax incentive for me? There are so many loopholes. There's tax avoidance, there's tax evasion. I can find ways to, you know, but then when it comes to like earning money, like revenue, that is gold to me. And I understand what you're saying when you're asking me to contrast the two, because in this environment, the upside opportunity is very high. Like you can make much more money, but the risks are also very, very, very high, which is why we're not seeing infrastructure like, you know, really build up as it should in the country. I think those are the two questions for me. And I'll have...
All right.
Okay, thank you. To go to, sorry, I didn't get your name. Dr. Ridwan, yes. I get your point in terms of publishing a directory of all the hospitals, and I think HEFEMA should be able to do that. So I'll take that recommendation back to them. And yes, it actually makes a lot of sense. You know, if you're able to refer, you know, a patient who is in dire need of, you know, medical services, you know, to a hospital not too far away than having to go to one, you know, 20 miles away just because it's a government hospital. So yes, I will take that back to them, the Ministry of Health, particularly HEFAMA, and also to the Honorable Commissioner for Health. To go to Madame Lola's question. Now, why do you have a situation where government halfway through negotiation, you know, is asking for more? So that's why it's called negotiation. So when you look at the entire PPP contracting process, you start from a place where you draw up a term sheet. So that term sheet has to be negotiated. From that negotiation, you also need to look at the financial model of the would-be concessionaire or the proponent. The financial model needs to speak to too many different assumptions. And most of the times, you know, when you look at the financing that would be deployed, it's usually a mix of debt and equity. You have to look at the payback period and also the return on investment and the internal rate of return for the concessionaire. You don't want to stifle your concessionaire, but at the same time, you as the grantor of the concession, you also need to make a decent return on the investment you're putting in. Most times for us in Lagos State, it is land, because land is our derivative. I have to value my land and not just use, you know, the concessionaire's value. Most times the concessionaire has already given me a value and they tell me, your land is worth 10 million naira. But by the time I engage an independent valuation expert, they're telling me my land is 65 billion naira. You see the difference, it's like night and day. So most of the times, when we are done with the negotiation in-house, for us in the Office of PPP, we also get one of the big fours to independently interrogate the financial model that has been sent by the concessionaire. It is at that point you probably see the goalpost moving and they're telling me your ideal revenue sharing should not be 3%, it should not be 4%, it should be 15%. Because when you look at the, what's the word I'm looking for? When you look at the, God, what's this word? The break-even period, yes, that's the word. When you look at the break-even period, you know, it is a lot shorter than they had already communicated. So if you're asking for more, and from the break-even period, you have maybe another 16, 17 years to go, why can't I ask for more? So they tell me, go back and demand this, because the financial model can absorb it. It can take that renewed ask for a higher revenue share, which is why we go back. And because we haven't yet concluded, I am still able to ask for more. The only time when the door is shut on me is when I am done negotiating, I am done executing, and I am now going to the House of Assembly to ratify. I can't go back to meet the concessionaire to say, oh, I want you to upwardly review my revenue share. No, because it's been signed and the contract is, you know, sacrosanct. So when you get that situation, you should ask your concessionaire to also be truthful, you know, and ask them, why is the state asking for more? Can your financial model absorb it? Do you want to go back and readjust your assumptions again?
All All right, thank you very much. Dr. Adeyemi, do you have one or two things to comment on? Just 1 minute, just 1 minute.
So largely, I just believe that based on what my colleagues here have said today and all, is that there are major 4 pillars that will successfully drive PPP home. Number 1 is that we have to have delegation of duty, alignment on roles of either the private and the public sector. Trust also comes in play and you have to, of course, lastly know the strength of each party. And this is the only way we can succeed, if we both have that alignment and understand our roles in this partnership. Thank you.
All right, thank you very much. A huge thank you to the panelists, and thank you everyone for engaging us. So now I'd just like to have a picture with the panelists. Thank you very much.
Thank you very much, everybody. I hope we enjoyed that very beautiful panel session. If we did, please let's give our panelists a round of applause again. Thank you very much. So we'll be moving on very swiftly to the next agenda for today, and that would be the fireside chat. We'll just give ourselves a minute to settle down, and then we move to the fireside chat. So the fireside chat today is proudly sponsored by Oncopadi, and then we're just going to give like a brief explanation of what Oncopadi is. So Oncopadi is a leading digital oncology platform in Nigeria and is focused on improving access to cancer care through telemedicine, patient navigation, screening tools, and virtual tumor boards. It connects patients, especially to those in undeserved areas, to oncologists, to nurses, support system via a mobile app. They are in partnerships with Roche, Pfizer, NSIA Lutz Cancer Center, and recognition from Astellas Pharma and the US IVLPAA. Oncopadi is bridging a critical gap in cancer diagnosis, education, and treatment center. So this fireside chat, we're going to be talking about strengthening oncology care in Nigeria, innovation, access, and multi-sectoral collaborations. So we're going to be inviting our speakers to come forth. We're going to be inviting Dr. Adaora Enyi. She is the Director of Innovations, Pearl Oncology, an award-winning physician leader and healthcare innovator with demonstrable experience in achieving SDG 3 goals across multiple sectors. She is the Director of Innovations at Pearl Oncology Specialist Hospital, Lagos, an Indigenous Women's Cancer Center, and she is the co-founder and COO at Oncopadi's Technologies Limited. Please let's give her a round of applause as she comes on stage for the fireside chat. Please let's not stop. The louder we clap, she comes faster. Thank you very much. So joining her on this fireside chat, we have Mr. Shino Arogundade, the co-founder and CEO of My Itura. He is the co-founder and CEO of MyItura, a digital health startup focused on improving access to diagnostics, electronic health records, and telemedicine in Nigeria. He is a Meaningful Business 100 honoree and a recipient of the Oni of Ife Royal African Leadership Award. With a background in tech innovation and venture development, he is passionate about leveraging data and technology to build a more accessible and equitable healthcare system. Thank you very much. So we're going to just move swiftly to the fireside. Okay, thank you very much. Sorry, my name is Favor Oluwaniyi. I am a medical doctor. Thank you very much. So first things first, we're going to start with, so we've learned about culture today. Please, how would you like to be referred? Thank you. Dr. Dora is fine. Okay, so Dr. Dora, we're going to be talking about oncopady and oncology care. I feel like a lot of conversation today has been about cancer care, and we've had a lot of conversations about cancer. So I think this is just going to take it like a notch deeper. So we're going to ask, can you share how your platform, no, before we even go into that, please tell us a little about oncopady, aside from what right now. What else would you like to tell us about oncopady?
So I say just from the name, and good morning everyone. A pleasure to be here. I see very beautiful faces. Learned a lot in the first session, very inspiring, amazing work being done, particularly across the Lagos State government and various other agencies. Also proud of the work HFN is doing. We're a member of HFN, and so we're proud of the work they're doing and their representation in actually fighting for equity when it comes to healthcare. My name is Dr. Adora A, but everybody refers to me as Dr. Adora, and I work at oncopady Technologies Limited. And a bit about what we do at oncopady, just as you rightfully said, we're a digital health innovation company that helps to bridge the gap, specifically for oncology. So our focus, niche down, is oncology care. And I'm sure what many of you know about Nigeria is that there are over 200 million of us. But what you don't know is that there are less than 100 clinical oncologists. Every year, Nigeria sees roughly about 125,000 new cancer patients. So that means one oncologist sees about 1,500 patients in a year. And that's very ridiculous when you compare it to countries like in the US or in the UK, where one doctor sees about 300 to 400 patients. It's a really huge burden. It's also worse to note that even though there are less than 100 clinical oncologists, there are less than 25 in Lagos State. In fact, 18 states in Nigeria do not have a clinical oncologist, right? So these 18 states specifically would have to have patients that are there, have to travel to those states where there are clinical oncologists. An example would be just our neighbors here, Ogun State, right? They have to travel down to Lagos. And so you can imagine some of the stress, the challenges that these patients have to go through. And that's really where oncopady comes. So we try to bridge that gap by connecting patients to resources, connecting patients to a community, connecting patients faster to these oncology services. I mean, if you're coming from Ogun State, what do you really know about Lagos? And then you're being told, go to this center, get care. You have limited information. You probably don't even have the contact details of those people you're going to meet. So you're going in there blindly. And so we help in the navigation process to sort of guide you through this process, because we understand that cancer care can be very, very bureaucratic. It's very challenging. The system is very fragmented. And so we're that guide, and just as the name is, oncopady, being your oncology friend to just guide you and navigate you through this complex cycle. Thank you.
Thank you. I feel like you answered a bunch of our first question, but I'm still going to ask. Can you share how your platform has improved access to oncology care, especially for undeserved population?
Okay, yes. So specifically for us at oncopady, we're proud to say that in the last 5 years of our existence till date, we've served more than 6,000 users, with about 4,000 of those users being cancer patients. And one thing was really common amongst the patients that we were seeing. many of them had either gotten a diagnosis, they were scared, they were unsure, they were afraid, right? And so this isolating diagnosis fell on their laps, and so they were not even sure how to navigate this complex healthcare system. Another thing was also a lot of them, if you know very well, cancer care or cancer treatment is financially toxic. It's expensive. The average cost of treatment is anywhere between 5 million to about tens of millions. How many of us have that sitting in our bank accounts waiting for a condition like cancer before we spend that money? So it's financially toxic. And thirdly was that even as cancer was fragmented and confusing, a lot of people were misinformed and even misdiagnosed. So there was a lot of and there still is a lot of misinformation, right? So you get a cancer diagnosis and you hear they're trying this kind of treatment somewhere, they're trying that kind of, there's just so much misinformation. In fact, and we have published studies to back this up, the average time it takes a cancer patient from the initial symptom to diagnosis, it's about 1 year. And so one of the things we've done is introduce some of our products. One of our most recent product called the brand product is helping breast cancer patients to shorten that diagnosis time from 1 year to about 90 days. So currently for every woman who sees a suspicious symptom in her breast, we're able to ensure that you get diagnosis and get into treatment within 90 days. And those are some of the impacts we're making when it comes to breast cancer. To talk more about some of our other products, one of which is to understand that breast cancer treatment or cancer treatment in general, whether it's surgery, it's chemotherapy, it's radiotherapy, or even palliative care, all these therapies come with treatment-related side effects. And so what you notice is that many times patients are disconnected from their care team when these treatment-related side effects occur. They are back at home, they're experiencing it, they are with their loved ones, you're having diarrhea, you're having fever, you're having all sorts of symptoms, right, that do two things. Number one, it interrupts your treatment, right? Because when a head and neck patient that is on radiotherapy, you can no longer eat, right? Trust me, you're not interested in going back to continue radiotherapy. You're more interested in solving that treatment-related side effect that will push you out of treatment, right? And then, of course, loved ones around are also confused, and everyone starts trying all sorts of things. And so what we've noticed is that in Nigeria specifically, there's a high burden of underreporting of treatment-related side effects for a lot of cancer patients, and that was what led us to build what we call the PROSCARE app. And so what the PROSCARE app does till date now is that it helps cancer patients who are on treatment to report their treatment-related side effects, but more importantly, get appropriate clinical advice on how to mitigate these treatment-related side effects. Until date, I think we have over 400 patients on the app that have reported more than 100,000 side effects and have gotten clinical advice, either in terms of take this if you're having diarrhea, take this if you're having fever, right, or present to the hospital, the nearest hospital, and we provide your medical records to support, the hospital. More importantly, in trying to solve that problem, we also noticed the gap, right? So even though we were referring patients to primary care hospitals, right, there was also that inability for primary care physicians to actually manage some of these treatment-related side effects because there was the knowledge gap. And so what we did was we launched a course called the StarPipe program, where we actually trained about 50 primary healthcare professionals on how to treat and manage treatment-related side effects as a result of cancer treatment. And till date, we've done that. The beauty about it now, in these centers where we've trained healthcare professionals, they are now managing patient side effects. And I think till date, as of today, we have 130 patients being managed across these centers. Thank you.
Thank you so much. So Ms. Tsushino, yes, how is your solution helping to shift oncology care from reactive to proactive?
Good morning, everyone. My name is Shino. I lead the team at Maitura. So I guess to answer that question, I'll first talk a bit about what Maitura is and why Maitura. So the idea of Maitura is to build tools that help close accessibility gaps between providers and users, right? And to allow for records interoperability and even access to that record. That way, allowing for continuum of care. You'd agree with me, oftentimes in Nigeria, I think one interesting thing is I'll be probably the only person that will sit here today who is not an healthcare person per se, So I'm coming from outside healthcare. But my experience is that, say for instance, if you need to see 2 doctors within a week, you probably have to tell your life story to the 2 doctors separately, right? You are not able to, when you talk to a doctor, the doctor's notes, you are not able to transfer it to another doctor. When drugs are prescribed for you by a doctor, probably if you go to another doctor within a week, they are prescribing related drugs. When you do a test with a lab, and you are going to another lab, when the doctor prescribes a test, and you probably do that test, you take the results to that doctor, and you have to go to another doctor for whatever reason, you have to repeat that test, right? These are things we are trying to solve for, or for people in remote areas where where there are no doctors. Earlier the last conversation, they were talking about how primary care centers in some parts, in remote areas, no lights, no doctors. Things are even worse for them. So how do we close that accessibility gap? In those primary healthcare centers where you have just maybe a receptionist or a nurse or somebody, how do we make it that people in that locality can still have access to doctors, can still talk to an healthcare person, get basic things in play? And that's the whole idea of Maitura. So today we've built a number of tools around that. We've built telemedicine tools, booking tools, the telemedicine tools such that you can deploy to primary care centers. We have APIs, telemedicine APIs that you can integrate into any existing platform. We have mobile apps, SMS services that a user can use to reach any provider. And luckily today, I say luckily because with the coming of AI, things are moving extremely fast, at fast pace. Today with AI, if I have your records, say your health records, now what I'm about to say, I'm scared I don't get sued for for data privacy issues. But yeah, if I have your health records with AI, yeah, there's also the argument of what's being used to train the AI. So right now my brain is thinking so many things. But yeah, if I have your records, so just pardon me, let me say this right. If I have your records with AI, I can predict certain things. There's not the argument of the data that the prediction is it applicable to local people. That's an argument. But let's just assume with the current data being used to train this AI globally, Mayo Clinic's data and the likes, if I have your records, I can predict certain things before they even happen. I can see biomarkers. I can see, oh, this person has the potential to have certain types of sicknesses, right? Which would not have been possible without that ability to have the records. So now coming to your question around being proactive rather than reactive, right? Because we now have this platform where if you have a headache, you could go ask an AI, oh, I have an headache, what could be wrong? And, and it tells you, oh, these are certain things you might have, asks you follow-up questions, you answer, then tells you, oh, probably you need to see a doctor, you actually need to see a doctor, or do a test or something. And then when we have your records over time, we can predict, we can help you, we can predict certain patterns, we can predict your potential to have certain sort of sicknesses. I think that is what we've now done today with what we have. Yeah.
Thank you very much. So I have a question that is not really in line with, but it was something, it was like a piggyback of what you said earlier. So you mentioned how expensive oncology treatment can be, right? And then our goal for PAHAS this year is redefining healthcare financing in such a way that it helps people, right? In what way, like for both parties, in what way do you think that Oncopadi or Maitura can help patients with cancer to onboarding that financial aspect? Is there like a partnership? What basically, in what way can they help? So, my...
Okay. I think the issue of financing, it's a tricky issue because the proper answer would have been health insurance, right? But health insurance adoption in Nigeria is low. Health insurance companies are not rich. They are very careful about cost. So there are things that are not covered. You wouldn't blame them. I like to give an analogy. In Nigeria, for instance, say 2023, at least I have the figures for 2023. All the health insurance companies in Nigeria combined did not make 100 billion naira combined.
Million or billion?
Billion. Okay. And that's not a lot of money, right? With that, you can't invest in innovation the way you want to now combined. But health insurance should be the way to go. It should be what, if you have cancer, it should be what you go to. Now, there's also the issue of when you don't have the cancer. You know, if you have cancer and want to get health insurance, it will be difficult in Nigeria. It's almost impossible. You have to have the insurance before you get cancer. Now, are there other avenues for financing for such? As of today, I can't think of any except out-of-pocket cost. But I know right now there are intentional moves happening. I know, for instance, there is this, luckily my Torah just got into one of such. So the Gates Foundation is working on something, creating this financing for healthcare, where people no longer need to pay out of pocket. They could get loans to finance certain things. So those are the options. But as of today, apart from insurance or paying directly out of pocket, it's quite difficult to think of any.
Thank you so much. You know, an amazing work being done by my Torah. It's inspiring to see when the other side, being those that are patients or those that have direct experiences with patients, are actually leading innovation that would solve some of these challenging problems. So to speak to financing, and I'll speak to it from 2 points. So the first thing we are very intentional about doing at Oncopadi is really identifying stakeholders and big players in the healthcare system where we can pool resources together. For one is with the Brand program, which is in partnership with Roche. We are supporting 5,000 breast cancer patients and providing them with free immunohistochemistry, free oncologist consultation, free dietitian consultation, and a myriad of services. And the value of these services combined is about 550,000 naira per patient, right? So that's a pool of resources. Other things we're also very big on is we're very big on identifying possible and viable clinical trials where patients can actually benefit from to just lower the costs. And we've done this with a lot of our projects in the past where we pay for certain services. One of our most recent one where we are helping, I think, about 50 women who are in line to have myomectomies and hysterectomies pay and cover the entire cost of those surgeries through clinical. So we are very, very invested in clinical trials. A second thing we're also doing is also engaging other stakeholders, non-health stakeholders. For instance, we've engaged with Access Bank where we designed what we call the cancer loan. So it's the W cancer loan, although specifically, and no bias to the men, but this is specifically assessed by the women. And it really makes sense because the two huge burden of cancers are the female cancers, being breast and cervical cancer. And so this W cancer loan is a single-digit loan that allows you to access the loan, upfront. All you just need to do is create an Access Bank account, access that loan almost within 48 to 72 hours of, creating that account, right? Get treatment, and loan is paid directly to the facility where you are receiving care. So, of course, all of that bureaucracies of you taking the loan and, disappearing and all of that is sort of a bit eliminated. But that's some way. And what we are now, preaching for, trying to get into is to see how we can sort of even remove completely the interest, even the single digit interest on it, in such a way that the loan is like a direct, because I mean, healthcare is a direct cost, right, when you think about it. Another thing we are also doing is we're working very heavily with the Nigerian Institute for Cancer Research and Training, and just as our HFN director had said earlier, where we talked about the National Health Catastrophic Health Fund, which is actually helping a lot of indigent patients that are on treatment, and it's over $100 billion naira fund that is being accessed by cancer patients. Another thing we're also doing is working very closely with the Nigerian Cancer Society. So the Nigerian Cancer Society has just recently launched the NCIF fund. So it's a National Cancer Investment Fund, where they also want to support cancer patients. And I think it's supposed to be a 100 million naira fund to support some patients. And they are working with key stakeholders. So these are some of the ways we're trying to pool resources together to sort of support these patients. But just as Shina has said, a huge majority of these payments will still remain out of pocket. So we now need to, as healthcare providers, we now need to look for ways to sort of drive down the cost. And one of the cost incentives that we do with our sister organization, being PEL Oncology, is that for many of our patients that have spent a certain amount, going forward, so once you've got into a cap, we cap it at about 5 million in your treatment. Once you've spent up to 5 million in your treatment, the rest of your treatment comes at a heavily discounted rate. Some services even come as free going forward. So the onus falls also on us as healthcare providers to begin to look at strategies and ways that we can sort of drive healthcare spending down, drive down the cost rather, so that more patients can be served, right? And, we can actually make the impact that we're looking for. Thank you.
Thank you very much. Please, I hope we're actually listening, because they are spilling good teas here. Okay, so my next question, which would be like my last question for both parties. From your experience, what are the key regulatory, infrastructure, or trust-related barriers that have hindered digital innovation in oncology? And how is Oncopadi navigating these systems?
Yeah, so I think in your question, you've answered it already. I think number one is, and it has been said so much, spoken about earlier today, is trust, patient trust. A lot of our patients still want the traditional way of receiving healthcare, right? You still want to go to your doctor, see your doctor face to face, be in the same facility with your doctor. But the truth is, healthcare really needs to revolutionize outside of how can we deliver care outside the four walls of the hospital? How can we get to those areas? And we like to say something like having healthcare in your pocket, right? Where you can take healthcare anywhere you go, just like in the fintech space, right? And you can access it from anywhere. And so I think trust is still a big barrier. And one of the things that a lot of health startups are doing is really increasing advocacy and awareness, right? And really sharing a bit of the impacts that we are making, right? The success stories, the case scenarios that we are making in addressing some of this trust gap. I think internet penetration is also still a challenge. It's an evident challenge. And I always say that for many of us that are in Lagos, we're sort of in a bubble, right? Even though, yes, it may seem like internet penetration is great. I've gone to places where they barely have WhatsApp. They barely have an internet-enabled phone. All they have is the normal, regular GSM. And even with the GSM, if you're not careful, half of that conversation on the phone, you're not going to hear it, right? So internet penetration is still an issue. And I know one of the things we're also doing at Oncopadi is, by virtue of an accelerator program we did with MTN, we're in talks to see how we can set up automated call centers, automated health call centers that can be manned by oncology nurses, where they can actually attend to some of these issues. Because just as someone rightfully asked, one of the issues that really is common is that even if you have a patient in front of you and you know that you can't manage that patient, you can't even refer appropriately because you don't have the information as to where to refer. Maybe the information on where you know to refer is kilometers away, right? And this patient, who's going to bear the transportation cost and all those costs associated with that referral. And so simple information on where to go to, what to do at every step of the way, and those are some of the things the call center probably help to solve. And I think lastly would just be a collective effort to everyone, be it you are a healthcare provider, you're a doctor, you're a nurse, you're a pharmacist, laboratory scientist, whatever you are, or you are a patient on the receiving end. The onus is on us to all still begin to come together to see how some of these issues, some of these digital literacy divide, internet penetration divide, infrastructural issues that we have, we can come together to begin to identify global solutions that already exist and see how we can localize them. Thank you.
Thank you so much. So my final question to Shino. In terms of innovation and scalability, what are the next frontiers Maitura is exploring to improve oncology care outcomes in Africa?
That's a question that requires me to think.
You had to say, okay.
Okay, yeah, thank you very much for that question. First, I think while she was talking, a challenge came to mind, and I think it's also something Ridwan said, the Dr. Ridwan here asked earlier. One of the major issues I think healthcare still faces is ability to pilot. I think where digital health is today in Nigeria is where fintech was, say, 2012, 2013. So yeah, there's room, but there's still so much to be done in terms of finding the right places to pilot, finding the right partners to pilot. So also on the question of the next frontiers. So for us, again, we're a digital health tech company. To building the tools. So for what are the things an oncology patient, a cancer patient will need, right? That accessibility to doctor at every point, ability to, symptom trackers, which is something she mentioned, the ability to maybe update your symptoms at every time, get immediate feedback, testing, access to testing, which is something we offer. Luckily, we've partnered with a number of labs. So testing at every point and getting your results quickly. Then your prescriptions, when you prescribe your prescriptions, finding the right places to go get those drugs, having it also on your platform. And probably community, right? At the end of the day, for a number of cancer patients, they need that community support. Someone being there, someone encouraging them, mental health, right? So providing that accessibility for the right psychologist or, psychotherapist, so to say, just giving them that access on the platform. Unfortunately, I can't think of anything AI right now, so I'm going to leave it at that. Thank you very much.
Thank you so much for your time. Please, let's give them a big round of applause. Do we have questions from the audience? Okay, we have one to any other person before we call it. Okay, we have 2 questions from the audience.
Thank you very much for the session, Dr. Adaora and Mr. Shino. So my question is to Dr. Adaora. So for patients that have cancer diagnosis before using Oncopadi and they're already registered in wherever hospital they are receiving care, so is there an onboarding system for them when they come onto Oncopadi such that, okay, if they need to contact their doctors, because some doctors too will say that because some patients can call them in the middle of the night for headache and fever, they will not give out their phone numbers. So if they're having symptoms, is there a way they can contact their oncologist so that they can receive that care? And also to for the patients that already know of their symptoms or already have established side effects before joining Oncopadi, are there things that we also tell them, or we just tell them, okay, whatever the oncologist has told them before, they should follow it? Then if there is any other thing that gets worse, they should now go back to their hospital where they are receiving care.
Okay, the next question.
All right, thank you very much, Dr. Dora. I want to very much appreciate you and Uncle Paddy for what you guys are doing. You guys have been able to bring down the time it takes for diagnosis from 100 days to 90 days. That's incredible. You guys have also been able to identify at least 100,000 side effects, offered follow-up during treatments, after treatments, addressed knowledge gaps that has helped, with treatments. That's a lot. In fact, it's my opinion that Uncle Paddy may be doing more than NICRAT. So I want to ask, in all this much impact, how close is Uncle Paddy working with public health facilities? Understanding that public health facilities are always primary, frontline. A lot of people, when they have cases or issues, concerns, they go to public health facilities firstly. How close, how involved are you guys getting them, especially with addressing knowledge gap, feeding them with these side effects, okay? Even also, how close are you working with NICRAT? In fact, you guys are on the front line, so I'm sure there's a lot you can feed them back with to optimize the efficiency. Thank you.
Thank you very much. So I'll start with your question. So in terms of staying connected with their care team, one thing we do very deliberately at Uncle Paddy with the PROSCARE app is that the PROSCARE app is an enabler, right? It doesn't replace the oncologist. It doesn't replace the need for the oncology center or the entire oncology care team. And what we do very deliberately is that we onboard patients as well as we onboard hospitals. So it's a two-way system whereby we're onboarding you as a patient and we are deliberate about onboarding your entire care team in that hospital. And so they run sort of like a schedule whereby they are able to empower other medical officers that are in their department, not necessarily the consultants or the oncologists themselves, or even the oncology nurses to actually manage you who already have your detailed history about your care, right, and still stay connected. And so the idea is you don't need to give out your phone numbers. You don't need to give out any personal information about yourself because on the platform, right, it has been standardized in such a way, and we use the ProCTCAE, which is a globally accepted standard tool for grading oncology side effects. So patients report it based on that graded tool. You get an automated clinical advice system, which is AI-powered. And for those that require severe, immediate, and urgent care, they are actually being triaged immediately by virtue of what we call a patient navigator that is present on the app that is assigned to you during your journey. So we try to still maintain the entire cancer care cycle within a closed knit. The goal really for us is that, unlike the traditional hospitals that don't have support, right? Most patients, once you get a cancer diagnosis, once you're on treatment, is only when you get to the hospital in the morning, they have the normal health talk, you get your treatment, you go home. Afterwards, you're saddled with sitting down on Google from morning till night and reading all sorts of things. There's nobody hand-holding you through that cycle, and that's really what we try to do. And then I think your second question was around, so the first was around communication, staying connected. And then I think the second question, if I can recall, was around the advice that they get. Right, so yes, the advice that they get on the system has been graded by oncologists. So it's not just a team, it has been an entire team, both global team and local team, that have actually sat down to standardize the advice that is being given. So it's not just only what your doctor tells you in the hospital. These advices are actually, and they are evidence-based. So one thing we are big on is we follow evidence-based guidelines, for instance, like NCCN guideline, which is readily available, and that's what we practice. And so we ensure that every advice that is given to you has evidence to back it up, and it's the right standard of care. Thank you. So thank you so much for your question also. yes, Oncopad is not doing more than NICRAT, and I want to put out that disclaimer. In fact, NICRAT has been very, very instrumental in supporting a lot of the work we do. We all know that in terms of digital infrastructure and the digital know-how, right? There's still a bit of gap, right? In terms of licensing and regulation, there's still a bit of gap. But NICRAT has been at the forefront of supporting us in just navigating this challenge as we go along. More importantly, is the brand program that I talked about was launched in March of this year in NICRAT. So it launched in partnership with NICRAT and Roche, and NICRAT handheld us through the entire process and has been working with us and making introductions for us to patients and connecting us, to community leaders and a lot of people where we're actually being able to onboard and support patients. So they've been very, very big on that. In terms of, please remind me, in terms of the second question around how we can bridge the knowledge gaps, right? So in terms of knowledge gap, and yes, we've worked very, very closely with public facilities. In fact, the StartPipe project that I talked about, all 50 healthcare professionals that were trained were from public facilities that are actually managing over 130-something patients right now. They were all strictly from public facilities, but specifically, they were primary care physicians, medical officers that have no prior knowledge about oncology emergencies, how to attend to oncology treatment-related side effects. We're also aggressively applying for more grants that can help us to extend, because one of the feedback we got, for instance, in some institutions that we went to, they had felt a bit biased as to why we trained only 3 people in their center when they had up to like 40-something people working in that center, and that was really how much the funds could allow us to do. And we wanted it to be fair and evenly distributed across Nigeria, so that at least centers in the north, centers in the south could at least get 1 or 2 per center, and that's what we try to do. But by God's grace, with more funding, we intend to expand the StartPipe project, whereby next year we're looking to see how we can train up to 200 healthcare professionals on this. Thank you.
Thank you very much. Thank you so much for your time. Just to be sure there's no other question. Okay, thank you so much. Thank you very much. Thank you. Okay. Okay, so while we're preparing for the next fireside chat, I'm just going to ask a few members of the audience questions, right? The goal of this is there should be like stirring of ideas in our mind, aside from a place of networking and all of that. It should also be that we don't just come for the event and post-event, we don't have anything to show for it. So do we have just maybe one person that would like to share what it is that they've actually learned so far in the event today? One person. Thank you.
Good afternoon, everyone. My name is Dr. Rosette Otiashong. So, from the beginning of the summit and also this last session that has been held, we see people, like speakers have been talking about reaching out to people. You know, I think communication is a big problem for us in Nigeria. And as Dr. Adora said, we have a trust issue, like patients and the healthcare system. I think for us doctors, we suffer it the most. I think the pharmacists don't have that serious issue with patients because I think because they are the last point where patients get drugs, so patients already have their solution. So patients are usually nicer to them. So when patients are violent, they're usually violent to doctors, they are worse to nurses because we are usually the ones there during like the heat of their problems. One thing I have seen is that when it comes to communication, when it comes to trust, we need better ways to explain to people that we are here for them. I'm a Nigerian just as you are, and for someone like me who is going to work like in like a public hospital, I do not get paid extra if more people are ill. Even if I see 1,000 patients, if I see 10 patients, I am still going to be paid the same salary. So one idea I would like to share with everybody here, anybody running any form of healthcare service and you want more people to get involved, especially like end users, patients. It's not enough to just speak grammar between us healthcare workers. It's to get volunteers from other walks of lives. So if you can explain to university students, not just medical students, not just nursing students, go into universities like oncology, for example. If you're able to explain to an economics student why they should volunteer with you, what this does is that it opens up oncology to non-medical people. Obviously, an economics student who is in second year has to explain to her mommy why she's leaving the house. So this is how we basically spread information about we're doing wonderful things, and many people don't know about these things, especially this cancer fund. Every time it comes up on Twitter that, oh, do you know that there's this fund? People are surprised. So I think that we should allow more non-medical people into our space, and this is one way that we can, onboard people. And because if you're not doing, if the help that you're creating is not getting to the end users, then we're not doing anything at all. Thank you very much.
Thank you so much. Thank you for sharing. Do we have any other person just before we move on? Okay. So we're moving on to the next fireside chat, and it is going to be about something I'm really, really passionate about: financing health, integrating banking and digital payments. Financing health, integrating banking and digital payment systems for universal health access. So we're going to be having Jenny Nwokoye, the CEO of Clafia, join us on this panel. So Jenny is a digital health platform. So Jenny is the founder and CEO of Clafia, a digital health platform revolutionizing access to primary care in Nigeria. With a background in systems engineering and global experience across Deloitte, AWS, and P&G, Jenny is driving impact through innovation, introducing Nigeria's first health savings account, and connecting thousands to affordable home-based care. She is a Forbes Next honoree and part of the Google's Black Founder. Please let's give a big round of applause to Jenny. Joining Jenny on this fireside chat is Ajibola Olumoko. So Ajibola currently serves as the Regional Manager, Government Banking, specializing in bridging public sector financing with digital payment infrastructure and health financing initiative. With a robust banking background, he plays a pivotal role in aligning government health programs with sustainable financing model. Born out of a commitment of advancing healthcare access in Nigeria, he focuses on integrating banking systems and technology with health sector needs, supporting initiatives like telemedicine funding, insurance disbursement, and digital health platforms. Let's give a round of applause to Ajibola Olumoko as he joins us on this platform. So I think he stepped out for a bit. Moderating this panel is going to be Mr. Ganiyu. Let's give him a round of applause as he comes on stage.
Is this working? Good afternoon, everyone. My name is Ganiyu. I'm a senior editor at Tekabao, and it's very nice and it's a pleasure to be here. So just Kenny, since we're here, we're waiting for Ajibola to come. So this is a very important conversation. When we talk about unlocking health finance, some of the questions that people often ask is, what is the use case for banking? What's the use case for digital solutions here? So Clafia works at the intersection of technology and health. So how can digital platforms, be designed to make health financing more inclusive, particularly for low-income communities?
Yeah, so thank you so much for that. The first thing I would say is really trying to understand the context of where we're building and the people we're trying to serve. Across different, socioeconomic backgrounds. I like to think of Nigeria as a whole as underserved, whether you're a high net worth individual or someone who lives in the rural areas, right? So what I would say is the first thing is just understanding who your end user is, who your customer is, particularly when it comes to health financing and the digital tools to support that. There's a lot of push for health insurance. And while I see a role for health insurance across the globe, I also know that health insurance is changing. Because, one of the speakers talked about it today. Health insurance penetration is very low, and yet the market just doesn't want it. Even if you have health insurance, you hear things like I went to the hospital and they didn't cover me, or I wanted to buy these medications and I couldn't get it. So what value are you actually getting from your health insurance, and what about the wellness side of things? So really thinking forward on what other things can be used, right? How do you reach your end users? At Clafia, we have a health savings account. So it works. You get access to a free health savings account, or HSA for short. You can start saving. You earn interest 10% per annum, and you can access discounted health and wellness services on our platform. It also allows those people in underserved areas that don't necessarily have a bank account, who are going to go to a hospital to access health and wellness, but they're told that we don't accept cash. So with our HSAs, you can get a free digital health wallet, and you can start accessing health and wellness today. With that, I feel like not only does it meet the end user where it is, but it also helps to introduce the end user to health insurance, right? If they're saving over time, could we now design a health insurance plan personalized for them, instead of giving them a health insurance plan that doesn't meet their needs, they don't understand it. And I'll just say for the first and foremost, education, educating the general public on what health financing is, what are the options available, why do you need it, right? At what point should you get an HSA, a health savings account, or health insurance, or a health loan? It's not at the point where you want to deliver or when you want to get cancer treatment that you should get health insurance or get an HSA, right? So those are the things I would say, making sure that when we are thinking of our end users, what I would love to see in Nigeria as a whole is that we design more solutions that are catered to us. And it's good to learn from what you see in developed markets, but we also can design for our own selves. I'll also be pioneers for that. As I mentioned, health insurance is changing, and I feel like we can be pioneers to show the world what other methods of health financing can exist. So I hope that answers your question.
Yeah, it does. Thanks a lot. I think what I particularly find interesting about your response is how to really rethink building, health financing solutions, because again, when you put the user in mind, then you're understanding what are like their own local peculiarities, what does their reality look like, how does that even play into how you design the products that are focused on them. But so one of the perhaps the very important talking point when we talk about health financing and scaling it is there are challenges, particularly with expanding into underserved communities. So from your own experience, what are those challenges you've encountered so far? Like, how are you coping with them?
Honestly, the biggest challenge is education. Education and awareness. You'd be quite surprised the average Nigerian doesn't understand what health financing is. They don't understand what health insurance is. Like, we just introduced a health savings account, and we're having to do a lot of education on that. And I think that is like one of the biggest barriers to scale. If you're trying to reach someone, the end user, you need to do some sort of education, and there isn't a lot of emphasis on it. Also, not a lot of emphasis on funding the education side of things. It's like, go start a company and be profitable, but there's so much like systemic issues around healthcare financing, healthcare as a whole, that if not solved for, will just impede scale, and health education is one of them. The second thing I would say that impedes scale is just infrastructure, right? Healthcare in Nigeria is very, very fragmented. You're dealing with a lot of different parties, a lot of different regulatory bodies. I like to think of Nigeria as like 200 million health systems, meaning one person is their own health system, because of how fragmented it is. They have their own specific way of accessing healthcare. There's no large system where like you have a critical mass of people, and under that one system, everyone is accessing healthcare the same way. So if you're trying to cater to that many people that have their own needs, that have their own methods of accessing healthcare, it becomes very, very challenging. So the lack of infrastructure makes scale for healthcare challenging. And then the third thing I would say is more like regulatory. There are regulatory bodies that exist in Nigeria for healthcare, but the incentives around the regulation that exists is not enforced. So it's there, but it's not enforced, and there are really no incentives to like help drive regulation. For example, like if I woke up one morning and I said I wanted to build a hospital today, I wanted to build a lab today, right? Like, what are the incentives for me to do that, aside from it's just purely capitalistic? So I just feel like those are the three things that that impede scalability of like health financing or healthcare in general in Nigeria.
Yeah, thanks a lot. I mean, I like that you touched on incentives, and I want you to delve more a bit on that, because again, when we talk about infrastructure, for instance, you made reference to the fact that there's an argument made for what government can do to support, health providers and, companies trying to build around this. What particularly are those incentives that, that need to be put in place to have more people, build health financing solutions?
Okay. To be honest, what I would say is, oh wait, my co-panelist is not here. He left me. Okay, I'll try to carry the fireside chat. All right. So I would say. So I would say, as far as incentives are concerned, one thing that I'm thinking about, but I don't completely understand, is taxes. I'm trying to understand that even as a health tech startup myself. Healthcare is a public good. Health financing is a public good, right? And to help encourage, more innovators, more private sector investment in it, I feel like one incentive could be taxes. You know, like, are there any, and I feel like there are, but that's one of the things when it comes to like regulatory environment. Like, I just found out that as a healthcare service provider, there are certain taxes I'm not supposed to pay as a business, but that's not generally known, right? So like, I feel like having those tax incentives generally known would help like drive innovation, would help like drive development, and I'm trying to see. I think that's like really it as far as like incentives from the government, and just making sure there's like an enabling environment. You know, an enabling environment like built on trust goes a long way. It's a lot. It sounds very like vague and broad, but it's, if you want to encourage more private sector investment or just development, I would say like the general, I would say sentiment of the country needs to be seen in a positive light, right? Like if I actually spend my dollars, my pounds, whatever it is, in Nigeria and wanting to like push the healthcare industry forward, like, am I going to be in an enabling environment at the end of the day to help it grow? Healthcare is hard. Healthcare takes time to really have its impact, but I still want to make my capital gains at the end of the day. So I think like those are the two things I would say like could help as far as incentive-wise for driving healthcare or health financing in Nigeria.
Thanks a lot. Maybe another thing to hijack would be that just need for more collaboration, because some of the things that you referenced, for instance, the fact that there are taxes you should not be paying that already pay them, it's because that sort of integration does not particularly exist, and something happens like across like all of the industries. So the question I was going to ask next would be, so when we talk about health financing, I mean, it goes beyond the section between, you know, technology and health. Now we're talking about, you know, finance partners, talking about banks and all of that. So how does that integration really play out?
Yeah, so I would say, I think it's just making sure you have aligned incentives, and if you're speaking to a financial institution, and making sure that you have someone in-house that truly, truly understands the healthcare sector. And that's what I kind of find is, I mean, there are financial institutions in Nigeria that have, you know, a desk for health, right? But do they really understand the peculiar challenges of a healthcare business to be able to provide healthcare financing for them? I won't say not always the case, right? So I think that's just the number one thing. You need to have like a champion in the financial institution that really understands what it means to serve like healthcare businesses for that financial integration to happen. I'll speak for myself, for an example. When we started off as a healthcare service delivery platform, and I mean, we still do that today, but we noticed that the number one barrier for our customers to access our services was cost. And we try to work with all different kinds of like financial partners in the beginning, or even health insurance companies, right? Because we're trying to think of scale and how can we reduce our costs, out-of-pocket spend, make it more affordable. But eventually, it took like a few years just talking to a few people, and eventually like, you know, it happened, right? And even at that, you know, for the financial partner that we have, you know, it's still a work in progress, like developing that relationship. So I just feel like just making sure you have aligned incentives, and then working with, making sure you have someone in-house that like truly understands, because I think there's a beautiful synergy between like health and finance. Like if you look at most developed countries, you'd see like healthcare and finance are like the biggest drivers of GDP in those countries. So making sure that these two like entities can see that there are synergies that can happen to help, you know, boost that. But aside from that, I think that's really the main barrier to entry, is just having a champion in-house.
Yeah, I mean, it would have been great if the Sterling virus was here. So I've asked him, how do we get more banks to like be, you know, more forward-looking towards that?
And
so
I would say like Sterling Bank, I would say like of all the banks that I'm aware of, I would say like they're pretty like forward thinking, like they required a few health tech startups. So I think they are a bit forward thinking in that regard, but it'd be nice to see other financial institutions or even fintechs like jump on board as well.
Yes, so the last question I was going to ask you mentioned in the course of the conversation that you launched a health savings account, so I want you to talk more about it, about how it works.
Yeah, so we launched our health savings accounts earlier this year. It's been, I would say, a work in progress for 2 years, but I'm really excited about it. So a health savings account, or HSA for short, how it works is that you open an account, you save money, and you earn 10% per annum on your savings. And on our same platform, you can access health and wellness at discounted prices in 2 ways. Through our digital care clinics, this is where you can speak to doctors, you can get your medications ordered, you can get diagnostic tests ordered either at home or at a nearest laboratory, specialist care, home care, all of that. And then we have a wellness hub where we've aggregated 3,000 health and wellness partners across Nigeria, where our customers can walk in and use their HSA to pay for like discounted medications, for example, or discounted lab services, or even gym subscriptions. So we have a partnership with SynLab. And with our partnership with SynLab, our customers get 10% off if they're paying for lab or diagnostic testing with their HSA. And it works just like a bank transfer. So if you're using your GTB Bank or Sterling Bank app to like pay for services, you can use your HSA to pay for that and get it at 10%. For gyms, we have like partners that offer 20% off, spas, skincare, healthy food, different hospitals, different pharmacies, mental health, all of that. So it's like a nice little ecosystem for health and wellness, so that when you do want to, and it helps to solve for 2 things. One, cost, and then like navigating a fragmented healthcare system. Someone talked about like being able to refer and not knowing like the nearest like hospital closest to you. Like on our platform helps you to do that with like geolocation and all of that. So that's essentially how our HSAs work. You can also use it to pay for health insurance too. So that's what I was referring to earlier, that we find that doing education and like having a health savings account is a good introduction to like health insurance. We've actually seen the increased adoption of health insurance because of our HSAs. So, yeah.
Thanks a lot. There's a lot of interesting text in one. We can take 2 questions. One, just one person? Okay.
Good afternoon, everyone. My name is Dr. Rosette Otiashong. I think that health financing in Nigeria is very unique because of the kind of people that we are. We have a God forbid syndrome. So people do not even understand why they have to pay money for something that has not happened. And it would be great if like healthcare systems or persons in healthcare really understand why people would not want to save ahead. I want to say thank you to Klafia for all that you're doing. It's amazing. But there's something very unique. There's something you said that I find quite interesting. And I really just want to know how it works. I'm currently starting my journey like in health financing. I'm just like an intern at Lashma. So I want to really just know like how you do that. So you said something about healthcare plans that are specific to a person. And if what I know about health insurance is correct, I just know that health insurance, at least at the basic level, is pulling of money together. So how do you make money from it? Because I would have waved that aside as say CSR, but you also talked about incentives. So you're obviously a company, an organization that wants incentives. So how do you walk through like having specific plans for people? Because specific plans would also mean that you're losing money. And my second question will also be that what's the immediate policy shifts that can happen right now that would actually like scale you to work as much as Ilera Eco? So what can happen now? Because you talked about regulations. So what can governments do right now that could literally just skyrocket you? So did you get my first question? Thank you very much.
So let me make sure I understand your first question. You're trying to understand how we make our plans personalized. So we do that a few different ways. The first way is how our customers are saving and spending on the platform and what they're spending it on. So we have customers that use our HSAs specifically just for wellness. So they use it for their gyms. They use it for spas. Like, could we like curate a plan specific to them, but also taking into consideration like future planning, right? Maybe let's say this person is like 20 years old. And just by like the data we've collected on them, we know that they will probably family plan. They might have a chronic condition because of their family history. Could we also start to bake those things in, introduce like some sort of like, I don't want to use the word like health insurance plan, but like just something that helps to take into account for those catastrophic things that will be expensive to pay for out of pocket. So that's what I mean by like curating a personalized health plan. And I think you were asking how we make money from that. Go ahead.
So basically, thank you very much. So basically, if you're doing that, would that also mean that for that person, you'd have to drop other services just because you've been able to like curate something that works for them? For example, one of the only reasons, I would not say one of the only reasons, but based on personal interaction with patients, one of the reasons why a young person might actually see a dentist in a year is just because they have it on their insurance. And I think that that's one of the benefits of insurance, because what insurance does is that it gives a regular person that opportunity to do like a wellness check. So my question is, if you curate a health plan, would you drop certain services, considering that those services are also one of the benefits of health insurance, or like having a health plan in general?
No.
Thank you so much for that wonderful chat. I hope that we had our answers to the questions that we had in mind. So swiftly, we're going to be moving to the next presentation. We're going to have a presentation from Ms. Omolola Dara, who is the Regional Head, Lotus Capital Limited. So Ms. Omolola has 18 years experience. Sorry. Sorry about that. So sorry for the mix-up. Please 1 minute. Okay. Okay. So we're going to have Miss Omolola Dara. She has 18 years experience that transverses marketing and business development, investment banking, stockbroking, training and presentation, Islamic financing and sales. She previously worked at Wema Capital, Independent Securities, Wema Group, where she conducted businesses development, sales, and marketing. compliance management, portfolio valuation, advisory services, and relationship management for larger local corporates and multinationals and HNIs. At Wema Capitals, she also worked in the subsidiary compliance department and customer service, where she headed the department to reporting to SEC and NIU, as well as maintaining client relationship. She later moved to Regency Asset Management Limited, where she was responsible for developing strategies to promote businesses, growth, customer acquisition, retention, and portfolio management as the head of marketing. She was also extensively involved in the recruitment and staff training. She joined Lotus in 2016. She is a chartered marketer and chartered personnel manager with a BEd in business education from Hamadu Bello University Zaria, Kaduna State. She also holds an MBA degree in international business management from the University of Lagos. She is also an alumnus of Harvard Kennedy School Executive Program. Please, with a loud round of applause, let's welcome Ms. Omolola Dara for her presentation.
Thank you very much. Good afternoon, everybody. Well, don't worry, I'm fine. Thank you. So I know we've been sitting for a while. I'm from Lotus Capital, and my name is Omolola Dara. I think I should have my slide, but I'll just make it brief for us. We're from Lotus Capital. I have some of my colleagues here. I have Akin Bade. Please wave. Akin Bade will be taking questions along with me. I have Olaiton and I have Olaide. It's a pleasure being in your midst. I mean, what we've been learning so far is about health. So when we were invited, it's just to talk about something that has to also do importantly with health. As we know, health is wealth. But before I go into saying health is wealth, I would like all of you to check your phone. We just sent you 5,000 naira each. Just check your phone. Feel free. It's your phone after all. We just sent you 5,000. Oh, you can see the smile. Everybody is blushing. Then you can just imagine checking your phone right now and you've been debited 350,000. So health is wealth. Two things. You are happy when you get that alert. Yes or no, you are happy. But you are startled or sad or scared when you get another alert that is not expected. So health has to do with wealth. It's very basic. Like you wake up, you are normal, you are okay, you can eat, you can talk. What if you wake up and you can't talk? And everybody, maybe probably in your offices, they've been telling you you make noise too much, you gossip too much. But for 2 days, if you can't talk, you will know health is wealth. Talking is also important. So I'll just go to our presentation. I don't know. Okay, building a healthier future. We are here to talk about our health, the untapped potential of ethical investment for sustainable healthcare development. We've been talking about healthcare, and I appreciate this program. The thing that is going to open our eyes to is how we can tap into the non-interest space or spare in Islamic, or non-interest or ethical financing. How we can, connect, tap into it, and see what we can, get. When I said look at your phone, it's because most of you know that we don't have your account number. If we had your account number, you will quickly look at it, and it will gladden your heart. But if you are just walking along the road and you hear probably an alert and you check your phone and you see you've lost 350,000, even without thinking, let's even assume the money, you don't even have up to 350,000. Immediately you see a 350 debit, you don't want to know whether it's 350 naira or 350 kobo. You will pause and quickly look at it. Oh, it's SMS alert. It's just 3 naira 50 kobo. So that's how it is. Health is the greatest wealth, and may we not be deprived of our health. So, why healthcare and ethical investment, why do they work together? Why do they work hand in hand? Basically, healthcare is a fundamental human right. It's something that we cannot deny. Everybody needs it. They've been talking about accessing it either by different platforms, digitally, by fintech, physically. In fact, you cannot gamble with your health. If you are given 100 billion, and one of your eyes removed or asked to be removed totally, you will prefer to have your eyes working. That is how important health is. There are people that are so wealthy but don't have health. So it shows that health cannot be gambled with. Then ethical investments, in Lotus Capital, first of all, we're the pioneers of Islamic financing. We've been around for almost 20 years, registered and regulated by Securities and Exchange Commission, SEC. We've been around, doing so many things, basically to promote ethical financing or non-interest financing. And the tenets or the importance is that the foundation is that there must be an asset. It's not money for money, like you have on the other side, which is conventional. Then it is important that it must add value to the society. It must be free and fair. All the things we are investing in or carrying out transactions with must be things that add value to life, not taken out of life. So that's why I appreciate the health sector that say tobacco smokers are liable to do what? Live long, die young. And they say drink. So those are the things we won't invest in. We won't do that. So we'll do things that are permissible, acceptable, things that add value to the society. So we also work along with health, things that are important to people, like clothing, feeding, fast-moving goods, things that add value. That's what we do in the ethical space. So in Nigeria healthcare funding crisis, we can see over 200 million Nigerians, only 55,000 doctors. Thank you for a doctor that has been asking so many questions. She's so outstanding, you see. We just have, and Dr. Reilwan just left. I think I've met him before. So we have just about 50,000 doctors. 55, and before you know it, maybe next month now you have Jackpa, straight to Canada. That's how it is. So we have funding gap. We have health budgets that is about 5.15, and so on and so forth. There are so many health things that they keep coming up with, but there is still a gap. Now, for us here, please, you can move on. For us here, what are the challenges? We can see that, one, in the health sector, all what they've been saying boils down to weak public infrastructure. Recently, we had the federal government Sukuk 7 precisely. How many of us have heard about Sukuk? It's federal government bond, exactly, but Islamic bond used for roads. And that, when I was told about this, I said, why didn't the health sector also come up with raising a Sukuk? Why didn't it come to their mind to also raise a Sukuk? After all, it's transportation that started the Sukuk for their own road, and we plied the road. Some of us passed through different roads, and you see all this road. Why didn't the health sector? Recently, the electrical sector is also trying to, start a Sukuk. So the health sector can also think of that. So weak infrastructure, brain drain, like I said. Most of the doctors are leaving. Low insurance coverage. Most people have spoken about that. Then limited long-term and private capital. There are no funds in the health sector. And in Lotus Capital, we have two things we do. We do funding. We fund people. We don't do startup business. You see, that's a problem for the health sector. But we fund. We fund pharmaceuticals. We fund hospitals, depending on the risk we're looking at. So we fund. Then we do investment, which is very important for us. And remember, I said health is what? Wealth. So we'll see some things that, go hand in hand with the two. So in funding, what is ethical investment? I've explained that before, so we don't need to go through it. Things we do: social responsibility, transparency, promoting equity, profit sharing, risk or no harm. We are regulated, and we deepen inequality. The benefits of why you are here: competitive returns. For us, in Islamic or non-interest based, in Lotus Capital, we make sure you get competitive returns. Everybody will ask Naira and Kobo. I'll show you what it will look like in Naira and Kobo. Now, it is important that even though we're in the ethical sphere, we should still provide competitive returns. It should be different from putting your money in your bag, under your pillow, or in the bank. You should have at least something for you to fall back on, either as an individual or an organization. So you'll see some of our return. Then value-driven growth. There should be value added to what you are doing. You know, if you put 10,000 under your pillow for 1 month, when you come back, how much is there? Are you sure? If you don't have your wife at home that used to steal your money small, that 10,000 will be 8,000. That is it. So it might not even be 10,000. You can put it in your savings account. You might still make 10,000. But if you run some kind of accounts that are hybrid, it might not be 10,000 because they will debit you for what? SMS alerts. So it should be something that's, sustainable in financing. I've explained a bit on raising sukuk, and I will also explain a bit on how we fund some organizations. Then alliance, capital with a purpose, diversification opportunity, help you to bridge wealth and opportunity gap, then promote community development. So those are the benefits. But before we move on, why should you invest? As a person, why should you invest? Not just in Lotus Capital, because we have different tiers, different types of investment. Investment could be in banking, it could be real estate, it could be in shares, equities, it could be, mutual funds like we do in Lotus Capital. But why should you invest? Can anybody tell me why you should invest? Basically, after all, you have money, you put it in a bank, yeah? Yes, so that your money will work for you. You don't have to. It's like transferring your risk to another person. It's stressless. Passive income. Something just comes for you. But why don't we invest? Most of us don't because, one, we're ignorant, or two, we're greedy. But when we hear of MMM, we are smart. That's the irony of life. When we hear of CBEX, all these funny things, pyramid, something, and it's always 22, 25, 30%, and we are not afraid. I fear us. We are so, as in, you are not even thinking that this person is making 30%. How, what is NPR? Where are they getting, we don't even reason it. We just, they said by tomorrow that 100,000 will be 250,000. How? So these are things we should always consider. Why should I invest, and why am I investing? When I tell people to invest, I tell you to invest, diversify. There are so many portfolios. In Lotus Capital, we have mutual funds. But you can diversify into different things because in Lotus, our mutual funds are divided into different classes, which we'll see later. There are some which have a bit of real estate, some are proper equities, while some are just like savings plan, where you put your money like, you deposit. So you have different ones. So there are some that are a bit risky, medium risk, or some that are not risky at all, where you can get at least your fund intact. Now, I tell people when you want to invest, there are things you should consider. One, liquidity. Am I getting my money back? It is important. And that is where the greed of man stands. Sometimes we are not even looking at the money we are putting in. We are already calculating the money that has not come. So you should be able to reason the liquidity. Am I getting my money when I need it? The access to my fund. 2, are these people registered? Go and look at all those they've scammed. Ask me, where is the registration document? Of course, everybody registered with CAC. Anybody can register. I mean, you can. Even online now, you can register a company. So anybody can register. But are they regulated? What are their testimonials? Who knows them? Who are their promoters? We don't take time to find out. Sometimes it's your wife, your cousin, your brother, cousin that told you that if you give me this money, I will climb ladder. You will climb after me. Then we will climb. But the day you enter, that is the day the climbing stops. So we need to be careful. Who are the promoters? Is this really working? Is it true? But you know the greed of men. Once we hear the percentage, some of us don't even know calculation. But once you hear 20%, your brain will start calculating. So we need to be careful. Then I tell people, apart from the testimonials, apart from the regulation, then is it ethical? Whatever they are doing there, is it logical? Is it, if I ask you now, the bank you put your money, what do they do there? You say they do savings and current accounts, right? So if I tell you in MMM where you put your money, what do they do there? What will you say? Mother, MMM. Mother, mindless and monstrous. You don't even know the meaning. So you don't even understand where you are putting your money. So when you are doing things, you should also be ethically minded. Because one day, you will leave all this behind and face your maker. Now, about Lotus, I don't want to flog it. We are registered by SEC. We've been around for about 19 years. We do fund management, financial advisory services, Sharia advisory services, and we are also the promoters or the parents of Lotus Bank. Some of us know Lotus Bank, so it's part of us. It's our sister company. So these are the people we've partnered with on and on over the years, so you can go on. So this is basically all the awards, all the things we've done over the years, all the clients, and these are the things you should find out about companies. Go to their website, check, find out. I recall there's one, I don't want to mention the name, it's in dollars, cryptocurrency, blah, blah. All this Gen Z, when they start blowing it, if you don't feel among, they will feel you are old school. So I felt among. So by the time they did, I said, okay, let's put small money. You get mail today. You get small money tomorrow. I said, this thing is sweet, though. I added small money. But because I'm very conscious. And when you know about these things, you just take your time. While they were putting plenty money, I was putting 50,000. I will convert it and just put 50,000 JJ. I saw people doing 500,000, 1 million. I said, hey, it is well with your soul. They will send message. They will give us small, money. This thing looks as if but I told myself, no more. I'm not putting a kobo. The very day all of us decided to withdraw our money, this is precisely 3 years later, we are still waiting. Precisely like 3 years later. They said it's turn by turn. Please, what kind of withdrawal? Even if you go to ATM and stand for 3 hours, won't you shout? You will shout. 3 years. In fact, we've stopped receiving mail. I'm very sure they even blocked me. Because the kind of mails I sent to them, like seriously? But that's how it is. So we need to be careful. So our investment products. I'll just go through the tail end. I think they will probably speak on it if we have questions. So we have Lotus Fixed Income Fund, which is Sharia compliant also. It pays quarterly dividend. It is for people who want investment that are at least low risk, passive income, like she said. It comes in, you get your dividend every quarter. It is cumulative of dividend. The projection for 2025 is 19%, meaning that if you have stayed in from the beginning of the year to the end of the year, 31st of January, you are looking at 19%. It is liquid. So you are not charged anything. There's no tax. It's open-ended. So you can come in, you can go out anytime. So who can invest? Anybody, either individually, company, family, as far as you have a name, a BVN, a bank account with your bank where they can be paying your dividend. The onboarding is seamless. So for the Lotus Halal Fund, this is of a bit of a higher risk. The projection for 2025 is about 22% or 23%. So meaning that if you've stayed, and right now, we've not even stayed half of the year, unlike the fixed income fund that has done roughly 10%, this has done about 22% as at now. So because a bit of it is invested in equities, which is the stock market, and the stock market is doing quite well, the remaining part is invested in real estate and asset-backed finance. Asset-backed is your lease, lease financing, LPO, and so on and so forth. So you have it there. So anybody invested in it, you are looking at like 22%. Yeah. So these are other portfolios. No, you can go ahead. The private portfolios for those that want to invest, companies and everything. Just go ahead. So in Naira and Kobo, that's just the example. If you're invested in the fixed income fund, a 50 million, that's what you have by now. That's what you are looking at for the halal fund. For 90 days, for those that are doing like term deposits, you want to just place your money from 100,000 and above, you are looking at 90 days at 13.25, 180 days as 14.25. So these ones are just like savings and investment, while those other ones are mutual funds. So this is just our address. Our head office is at Lotus House, Awolowo. We have an office in Abuja. We have in Kano. And like I said, the best time to always invest is now. You know, the best time to plant a tree, they said was how many years ago? 20 years ago. But or 10 or how many years ago? But the best time, you know, I look at it. If you look at yourself 10 years ago, look at the mirror, look at your pictures. You were younger. You had that energy. You had that vibrancy. Add another 10 years. Add another 10 years. You are getting older. Cut down the chocolates, the shawarma, the ashwebi, the drinks. Cut down, apart from your personal health. Cut down all those little, the suya, the taking out the girlfriend, the feeding the boyfriend. Cut it down. Start saving now. The best time to invest, either as an individual or a company, is now. So for Lotus, we're open to funding, we're open to investment, whichever you are available for. For funding or financing, let me just say it, for financing assets, we finance assets for individuals or companies that are registered. You've been in the business for at least 5 years, and there are rules, there are regulations for that. While for the investment arm, anybody can invest, any product of your choice. You are free to meet any of us, get our flyers, and discuss what is best suitable for you or your organization. Thank you very much.
Thank you very much. Do we have any questions for Lotus Capital? Do we have any questions for Lotus Capital? Okay. Thank you very much. Okay, so we're going to be going on a very short break now. We realize that we've been sitting a lot all morning, so we're going to be going for a very short break, 5 minutes. We can walk around. Then we also have refreshments for us in-house. So yes, we're just going to take like a 5 minutes break, then we'll come back for the final panel session and a presentation. Thank you very much. Please let's give her a round of applause as she joins us. So moderating this panel session is somebody that we have seen, but I failed to introduce the first time. So Dr. Adewumi Akingbola is a medical doctor, trained infectious disease epidemiologist, and the founder of Health Drive Nigeria. He is dedicated to advancing global health through data-driven public health interventions. He earned his medical degree from Lagos State University College of Medicine and completed a master's in philosophy, in population health sciences at the University of Cambridge, graduating with distinctions in infectious disease. At Cambridge, he was awarded the Public Health Early Career Research Prize for his thesis on innovative approaches to managing missing data in hepatitis C prevalence studies among people who inject drugs, contributing practical insights to improve disease surveillance and health equity. His passion for tackling complex health challenges has earned him several international accolades, including the 2020 AfriSafe Award, the 25 Under 25 African Leaders Award, the 2021 Diana Awards, the 2024 Passion in Science Award by the New England Biolab, and recognition in Forbes 30 Under 30 Europe 2025 in Science and Healthcare. These honors reflect his impactful work in infectious disease control, particularly in raising awareness and delivering intervention for viral hepatitis in low-resource setting. I feel like we're about to have a very wonderful time with this panel session, so let's enjoy.
All right, everyone. Good afternoon once again. And I'll be moderating this panel session, of which, as Favor said, the topic is From Vision to Reality, Financing Solutions to Bridge Africa's Health Infrastructure Gap. And with me on the panel is Dr. Osa. Oh, I'm so sorry. Dr. Osa and Dr. Adebomi. Oh, just Adebomi. Oh, all right. So thank you very much for joining us on this panel. And Favor, we have somebody online, right? Yes. We have Elijah. All right. Thank you very much, Elijah, for joining us virtually. And so as we've been discussing throughout this summit, health equity, as well as access to innovations in the healthcare space are actually very important conversations for the lower to middle income countries, especially like Nigeria. And then as much as this may not be the reality of some of us here, because due to one or two reasons we have privileges, right? It's the significant reality of a lot of the Nigerians, most especially Nigerians that do not have access to information, and most especially do not have access to hospitals, right? So the core of this panel session would be to address and to probably prefer solutions and to how we can actually bridge the infrastructure gap, right? And my first question would go to Dr. Osa. As I said earlier, access to quality diagnostics is critical for healthcare delivery. So how do you think we can help bridge the infrastructure gap for diagnostic services, especially across underserved regions? So would like to hear your thoughts on that.
Thank you very much. A correction, right, that I want to make. I worked for, who made read the citation, right? Yeah, a bit of a mistake, correction or addendum to that is that I now work for ISN Medical. Oh, yeah. So to your question, right? Yeah, so there is infrastructure in our setting, you know. I like to refer to our setting as resource manageable, not resource poor, resource manageable. Because we have the resources, but we need to manage the resources. Okay, so one of the main things, that we can do, or that is critical, right? Financing. And it's not always every time the bank, right? When the Mrs. Odoye was here, she said that government brings land. Let me rephrase it. When it comes to financing, financing is not always just the hardware, right? Software hardware. There's also something that we forget. There's capacity. Human capacity is also a critical part of financing. You cannot put, when we go in as private partners in some of the spaces, the human capital that's there, if you want to put money to it, it's difficult. So the human capital is also part of financing. Now, if we talk about financing, there are so many ways that we can do it, so many ways that we can bridge infrastructure, right? Infrastructure gap. Financing, capital, human capital, and I would also want to add technology, right? If we talk about the financing part, like I said, doesn't always have to be the banks. We, as the private partners, public sector, there are other ways that we can finance. We can get financing from, I think they refer to them now as impact investors, people who want to see what you have done and are willing to finance what your plan, what you're looking at. And impact investors also want to see that you have already done something along that line. Even if it hasn't generated the hundreds and billions of naira dollars that you are thinking, but at least you've done something, right, that has generated some money. They want to see that. Then another form of financing again is where we look at micro financing, right? Small banks, not necessarily microfinance banks, but they are like microfinance banks whose focus is on healthcare. The private sector, are always able to access those particular form of financing in a way that they already have track records. They've not done so much, but they have track records. So they're able to access that kind of financing. Then the human capital part is very, very, very critical. The Jackpot syndrome that we are seeing, it is, you cannot imagine. Some of you here are doctors, some of you are in other parts of healthcare. Okay, please, let me just ask. How many of you here are doctors? I'm a doctor. How many of you here? We are not much. Then let me go to the next one. How many of you here are radiographers? Nobody. How many of you here are lab scientists? Just 2. That's how bad it is. The human capital is so strained right now. So, bridging that gap, that whole workforce gap, which is also critical again, we need to put in, I don't want to say financing, but some form of financing. Not just salaries, not just the pay better or pay more. The equipment itself that we are all going to use also adds up to the financing that we are looking for. Let me stop.
All right, thank you very much, Dr. Osa. So still with you, from what you've said, in my head, it looks like we have 2 categories of financing. There's the business financing aspect where you have to pay for, you have to pay operational costs and all. And also there's the financing on the part of the patients for their out-of-pocket expenses. So I'm curious to know, what is the effect of the NHIA, that's the National Healthcare Insurance Act? What is its effect on the patient's out-of-pocket financing currently from a diagnostic standpoint?
Okay, so from the diagnostic standpoint, NHIA is is like something that's smaller than a pebble. That's sincerely speaking. That's what, you know, it is. People talk a lot about healthcare insurance. We talk a lot about it. But the lady that was from Clafia, she said something critical, which is a lot of the plans that are out there do not fit us. They are generic plans. The plans are just put there so that the NHI and the other insurance, healthcare insurance companies are seen to be doing something. However, there is more to it. And a lot of the insurance, they don't cover some of the critical things. They don't even cover some of the ad hoc things. Like, for instance, let me use this as an example. Let's say a 60-year-old person, right, decides to do one of those plans, not the low one, let's say the middle one. Middle one is not going to cater for diabetic management. They don't. And at that age, that is what we should be looking at. So a lot of times, the insurance just caters for the malaria, headache, being able to go to the hospital and do an abdominal ultrasound. But there is more to what insurance can do. So insurance is like a pebble. And it's not yet that kind of pebble that you would throw into the ocean that it's going to form the rings, you know, that you want it to form. Yeah.
All right. Thank you very much. Thank you very much. I think that you have hit the nail on the head, because the last time I checked statistics of NHI uptake. It's about less than 3% of the country. And,
yes.
And I'm thinking, if less than 3%, and I am very sure the 3% would be informed individuals. Right? So if the informed individuals that have adopted the health insurance are just 3%, how about the vast majority of the less informed people? So, I mean, it just means that we have we still have a lot to do on our hands, and I'm really hoping that from these conversations, solution would be created and uptake and taken up. So, Ma, you are from JEE, right? Jackson Edu. All right. So, we would like you to tell us what key financial and legal bottlenecks do you think are currently limiting the development of Africa's healthcare infrastructure, and how they can be addressed?
Okay, thank you very much. You know, when I was coming, I saw the topic, and I said, I think we already know what the issues are. I think that what we need is implementation, and a lot of these things, we need to start implementing them rather than just talking about them. First and foremost, I believe that we need to create an enabling environment for, you know, the health sector. There are so many laws and regulations and, you know, all of that, and it can get a bit confusing for healthcare practitioners, you know, from going from one regulator to another, trying to get a license and all of that. So there are so many bottlenecks that we have within this sector. Your question is to Africa, and I would say that Africa still has a very long way to go. Take, for instance, in the UK, the health insurance and all of that in the UK is majorly funded by investment, the institutions, is not funded by the patients. Here in Nigeria, what we have is that a lot of the funding comes from the pocket of the patients that are going to, you know, the hospitals, which is not supposed to be so. So if we create an enabling environment in a country like ours, like in Nigeria and in Africa, we will have so many other people want to invest into the system. They will be confident enough to say that, okay, this has government backing, this has the institutional infrastructure backing and all of that. And they will be confident enough to invest. You know, recall that as a businessman, if I'm investing for profit. I'm not investing because, you know, I just want to be philanthropic. What we have right now
for people that are investing in the healthcare sector are those that they're just philanthropic in nature. They're like, oh, let me just invest because this is, towards a good cause. But if we have government backing, if we have institutional backing, there'll be a lot more faith in the system, and people would be willing to invest. And if we create that enabling environment for them, a lot of these issues, I think a lot of the bottlenecks would go away.
All right. Thank you very much for that comprehensive response. But also, I mean, is there a particular legal bottleneck that you can identify or you have identified from experience? Just one bottleneck that you feel would be responsible for majority of Africa's delayed development in the healthcare sector? Just one.
I think that the issue stems from a lot of people are not aware of many of these acts and laws, and they don't even know what it. When the draftsman are drafting the act, they draft lawyer, they draft that. So a lot of people do not even realize that there are some of these things that are already provided for in the act. So there's limited knowledge. I think that if there's more awareness, people would be more aware of the things that that can cause all of these bottlenecks. Because when you go to all of these institutions, for instance, if you want to get a license, you probably need to go to NAFDAC before you can get to, in fact, you start from CAC, registering your business, heading to NAFDAC, heading to all these regulatory bodies to get approvals before you can even start operations. I think that if we have all of this consolidated in such a way that there's a one-stop shop for everything, issues like bottlenecks would be cut short.
Cut short. All right. Thank you very much. So to Elijah joining us online, we all know that access to reliable diagnostics is very important in healthcare delivery across the world. But from Unimedical's perspective, how do you think innovative financing models can actually help us to bridge the infrastructure gap for advanced in vitro diagnostic services in underserved areas across Africa?
Okay, so thank you very much. I would have loved to be there physically, but I'm here for the ongoing CMD's conference, Chief Medical Directors Conference here in Medjugorje. So thank you for your question. And then now, one thing we'd have to know is that infrastructural gaps in diagnostics are not really simply as a result of limited technology, right? They are a function of, or they are a mix of unresponsive financing mechanisms. Now, to unlock access to, let me use the word underserved region, using West Africa, or particularly Nigeria as an example, we must deliberately, intentionally redesign the healthcare and how it is funded, how it is owned, and how it is utilized. Now, using Unimedical as an example, at Unimedical, we have pioneered innovative, well thought of financing model that addresses real-world barriers that we have faced. And a few of them, let me mention PPP, public-private partnership, which is a situation or a model where we have an understanding with the healthcare facility, maybe public or private facility with good workload, and then they hand over the lab to us, they give us a space in the lab, we bring in our analyzers, right? We train the scientists there on the maximum usage of the analyzer, and then there is profit sharing at the end of the day, maybe 70-30 or 60-40, as the case may be. Now, the facility also provides the space and electricity, right? So this is PPP in summary. However, it has several challenges, especially in the parts of the healthcare facility part meeting to the understanding that is signed. We've had situations where it is not really appreciated by some lab scientists because they would think that we are taking their job. So this concept, however, aligns with the government's shift to outcome-based financing, right? And then it also encourages fiscal decentralization. This was what I was discussing with one of the CMD in the Northern healthcare yesterday, right? We have a discussion bordering around PPP, and I was telling him the solution we have, which is what I've listed. And another solution to healthcare financing also would be what we call placement or reagents rental, right? So in this situation, we intelligently spread the price of the equipment on the reagent over, for instance, a period of 5 years. Now, this works for hospitals that have relatively medium to good work volume because it is work-based dependent, right? And then the expanded value of this concept is that it drives high utilization and accountability, right? It builds asset ownership gradually because at the end of the placement duration, the analyzer or the equipment belongs to the end user. And we've had this partnership with several hospitals in the north, south, east, and west, right? For some sensitivities, I may not want to mention them. And it also lowers laboratory startup costs by a good percentage. This is also ideal for primary healthcare and secondary healthcare and some qualified primary healthcare. We have this discussion also with the state government of some underserved region in Nigeria where we are looking at utilizing the placement and PPP model or a mixture of both to automate their IVD laboratory. Now, the last solution we have in this category is what is known as half purchase and half placements. You know, it's simple, right? You pay 50% upfront for the analyzer and we spread the remaining 50% on the equipment over a defined period of time. So these three models I just highlighted are what we in Unimedical have defined or have is part of our solution to financing the healthcare in underserved region. Now, financing is not just a bottleneck, right? I see it as a gateway. So when we think ownership model, we unlock access to life-saving diagnostics for millions. You know, so we are in business to make profit, right? And then this financing model I've just listed has defined mechanism where the partnering laboratory or institution understands the period where they will start getting their ROI because we go as far as calculating the cost per test and there are no hidden costs. So yeah, these are part of the solution we provide in healthcare financing.
All right, thank you so much, Elijah. But I'm also curious to understand. So from your experience so far, what is the major barrier that you've seen that health facilities face when they try to acquire this in vitro diagnostics infrastructure and equipment? I know, first of all, funding would be a critical factor. But aside from funding, what other barriers have you encountered that public facilities, especially public facilities, would face? And I mean, if you also have key experiences of the private sector acquisition of these infrastructures, you can also tell us what the barriers they've faced and that you've seen. Please, you can go ahead. Elijah, sir, are you still with us? Okay, we'll come back. We'll come back to that. So, before I go to my next question, please, I would like the audience to also gather their questions because after this, I'm going to take your questions. So, back to Dr. Osa. Exactly. So, I would ask a similar question from your point of view. What are the biggest barriers that health facilities, both private and public, encounter while trying to invest in diagnostic infrastructure, and how do you think these barriers can be addressed?
Okay. So I think we flogged funding. Yes, I think we flogged funding. Another barrier is infrastructure. Yeah. There's an infrastructure lack in in our countries, in this region. Infrastructure being power, utilities generally, power, water. These are very critical you know, and of course, like I said before, workforce. In the case of power, right, Miss Ali, right, Lola, she spoke about what happened to her, and they had to go and get solar panels. That, I think, is one, it's a major solution, right, in resolving the power situation. If you're, and then if power is...
I'm not sure at what point was I cut off. I was actually...
Mr. Ledger, yeah, don't worry, we would get back to you very soon. Yes, just stay with us on the call. We'll get back to you very soon.
Okay, so like I said, power, water, we are all governments, entities unto ourselves. The same thing happens with the centers. They have to get their own generators. They have to get their own solar powers. They have to dig their own wells, their own boreholes as well. Then another thing again that also we don't see it but is there is space. It is space. Some of you are looking at me funny. Now let me explain what I mean by space. You go to a hospital and hospital says we are a 20-bed hospital. What you expect to see is maybe like half of this hall should be able to take 3 beds. Am I right? Yes. But what you see is half of this hall taking 5 beds. Space is another critical factor that's missing, right? That we don't understand in the healthcare sector. If someone, the person you just come out of surgery, the person next to you has a viral infection, what's going to happen? That's exactly what's going to happen. So space is also another critical thing that we lack, you know, infrastructure. And again, back to the same thing, the workforce is another critical lack.
Critical lack, yeah, especially that workforce, because I was at the Lagos State University Teaching Hospital, and I met one of my consultants, and he was telling me that he himself was planning to resign because the workload is already too much. That for many months, they were running the hospital in his department without resident doctor. It was literally the professor, the consultant, and the house officer. And he is also doubling as a lecturer. And now in the College of Medicine, they've over-admitted students, and he has to, every year, now supervise 20 students' final year research projects with his clinical work. So he honestly wants to resign. So, and I mean, just looking at the general outlook of healthcare workers in the hospital right now in Nigeria, I mean, I can already see that there's a lot of straining. And the problem is not even that there is a lack of expertise. It's just that, I mean, people are leaving the country. So 10 years ago, workforce was not a major factor. But now, I mean, it's at the forefront, even before funding. Yeah, so I think that's very important. Mr. Elijah, are you with us?
Yes, I'm with you, but my network is quite unstable, but I'm with you.
All right, it's all right, sir. We would manage. So I asked before that from your point of view, your experience, what's the most significant barrier that health facilities have faced?
Okay, so maybe I will just switch off my video if it will be better.
Yes, that's fine also. So from your point of view, what are the major barriers health facilities have faced while they were trying to acquire these in vitro diagnostics equipment from you? I mean, apart from funding, I mean, what were the other issues that you identified that these people had?
Okay, so these are real-time, real-life situation. Practical example is what I'm defending with my CFO. If I'm allowed to mention, no, okay, for some sensitivities, let me still not mention names. A particular government hospital is owing us quite some millions, and then they still want us to supply reagents, right? So number one challenge we are facing with especially government facility is payments as at when due. This is a facility we gave 90 days payment time frame, which is 3 months. And then in the space of 3 months, they've consumed a huge number of reagents. They have not paid. With that outstanding, they are still requesting for, right? So keeping government facilities, especially keeping to their part of the bargain, it's a real life challenge for us. Now, so what we have done, or what we are still modifying in Unimedical, is that we try to create a business model for the CFO and the MDs to justify the return of investment, because we are actually in business, though healthcare business, but the bottom line is to make reasonable profit or some minimal profit, not a charity organization. So having facilities, renowned facilities, not keeping to their part of payment is actually a real-time challenge for us. Also, not keeping to their part of the payment is one. Delayed payment is one. I'm pretty much sure Dr. Sorry, I would call her name because I think we are mutual, we are friends on LinkedIn. Dr. Osayu More, I'm pretty much sure she has experience with being, I trust using ISN, and I know she has experience with dealing with government on those that have huge outstanding, even spanning into years, right? There are some debts we may even have to write off because it's been more than 3, 4, 5 years. So a solution that we have drawn up and we are still modifying is known as credit vetting system, milestone-based invoicing, flexible payment timeline tied to hospital cash flow, and then we have developed good relationship with those in the accounting to quicken the process for the paperwork moving from table to table. In most of the cases, or in facilities where we have placements or PPP, we usually have, or we are now having closer understanding with the chief medical directors, with the CFO. We are now having routine meetings so that we would understand their situation, and then they understand our pain points, and then we are able to meet our at a point. Has it worked? Well, that is a question maybe one would have to answer another day. So these are real challenges. We are still thinking on what is the best offering or what is the best solution, because if we don't supply or if we don't meet their needs, being a government facility, competitors, we are giving room to competitors to even meet their needs, because these are renowned hospitals we use as reference centers. So these challenges have been a bottleneck to us, why we are still flexible in trying to create a valid solution, which in most cases is even beyond the capacity of the healthcare, and it would involve the government to look into it or to intervene. So these are situations that we face, and it's still a challenge still now in healthcare. Thank you.
All right. Thank you very much, sir. Thank you very much. So, do we have any questions for the panelists? Does anyone have any question? We'll take like 2 questions. All right. Sorry. Just hold on. Someone will get the mic. Yeah, so please, just tell us your question in 1 minute and be brief as possible.
Thank you to all of the speakers. So my question is, we mentioned the NHIA, and you mentioned that there's still 3% take-up of the NHIA. I believe that one thing is this is a comment. So I believe that one thing that is also part of the reasons why people are not also taking up NHI is because it's no longer covering as much as it used to when we were much younger. For example, now if I want to use the NHI, there are some tests it does not cover. Sometimes it does not cover full blood count. I'm like, oh, what's the point of the NHI that I am paying for if it's not even covering something as simple as a full blood count or an EUCR? So I feel that is also part of the reasons why, although I understand that it also might not have covered because there's no funding, because people are not also taking it up, but I do now know how to implement it, but this is just a comment.
Yes, all right. So the second person, yeah.
Thank you. Good afternoon, everyone. My name is Dr. Rosette. My question is to Dr. Osa. So, you've spoken about how we flogged funding enough, but at this point, funding is still our problem. So my question is to you, with your expertise, what do you think would make our healthcare system bankable enough for investors? Because as Barrister has said, we have a problem because the way we get our insurance money is by pooling of money. So we need like investment. So how do you think we make our healthcare bankable? And also, I need this answer from you. I want you to tell me, ma'am, please. Do you think that one of the problems we also have with our healthcare system is also because of management? Would you recommend for non-doctor managers for teaching hospitals? So like, you know how in our teaching hospitals, we just have like persons who are now consultants being CMDs. Would you recommend that we bring in like the economics guys? It's not just enough to have a medical degree and maybe get an MBA. Would you recommend that we start? Because at this point, we need help. Do you think that this is a way forward? So first question is, what do we do about the funding? And do you think that this is a management problem and we should now shift to non-doctors? Thank you very much, ma'am.
Let me answer your second question first. I believe, right? I know we are doctors here, I'm a doctor as well. But I believe that all doctors should not run hospitals. Let me tell you why. When we go to medical school, we are taught how to treat the patient. In our own setting, we doctors see ourselves as demigods, but we are not. We have 0 to 10% knowledge about management. We do not even understand stakeholder management. And your stakeholder is also your patient. We don't. What we doctors see, I'm a doctor. Call me doctor this. Madam, what is wrong with you? Well, is it global? Is it half? Is your eye twitching? That's what we see. That's what we do. It is so different from managing businesses. Healthcare, please, first of all, I know we are Nigerians and we are from other parts of the world, Africa. First of all, healthcare is a business. Please, let's understand that. Healthcare is a business. We chose to enter the healthcare system, doctors, radiographers, medical lab scientists, because we wanted to treat people, we wanted people to get better. But nobody told us that for them to get better, and they need to take Panadol. Panadol is not free. Panadol is paid for. To that question, as far as I'm concerned, if any doctor wants to become a teaching hospital, let me not even say teaching hospital, that's big, that's huge. Let me even say a 20-bed hospital manager. You must, it must be a criteria from HEFEMA, Ministry of Health. You must go through some form of leadership and management training. And when I say that, I also mean that, break that down into understanding plus profit and loss, plus and minus. One glove used by one doctor's hand has a cost. We must understand that. It took me a while to understand that. If we don't get that, our hospitals will continue to suffer. That's the truth. Now, in the funding, this, the whole funding thing, why I say it has been flogged is that if we use a country like the UK, right? Europe, for instance. I've lived in the UK, right? Funding is tax. Somebody here asked about taxing. Funding is tax. You earn well, you pay good tax. And then you access the NHS. In America, they have insurance. Insurance is crazy. However, for those who have access to insurance, the insurance works for them, right? But those that do not have access, it doesn't work for them. Health doesn't work for them. But there is one thing in American hospitals that you would have seen, for those of you that watch a lot of healthcare programs, they what's that, indemnity? Yes. The doctors take, all the doctors, they take indemnity, that's insurance. Indemnity. Hospitals are hedged by investors. Now, she said something, healthcare is so fragmented. You are, let's say you are an endocrinologist. You own 5 beds. You are a cardiologist, 10 beds. Excuse me, what are we doing? What are we doing? You mean you can't partner with her? Who you are seeing will come to you. Who you see will go to her. Create a partnership. The partnerships, the collaborations that we do is what will make investors interested. AMCE that was just launched in Abuja, massive hospital. Please, I'm not slighting, I'm for it. Where are the professionals going to come from? Let us ask ourselves that question. Where? Not the doctors. They are doctors. Yes, the nurses, cardiology nurses, orthopedic nurses, then the lab scientists. Where are they coming from? I ask this question when I come across healthcare people. Again, I will say it again. I'm a doctor, so I have a right to say all that I am saying because I've been in this industry over 20 years. I've been in this industry. I have walked the corridors of public service. I have not worked for public service, but when I say walk the corridors, I have met and I have sat down. But the question comes back to us in the healthcare space. What do we want? If we in the healthcare space cannot define what we want, we will continue to be tossed, and that's what it will always be. The accountants know what they want. You cannot go into the bank and bamboozle the GM. I wish the guy from Sterling Bank was. You can't go there and tell him that, oh, I'm a doctor, I want to open a hospital. This is the vision I have, 15 beds. No, you cannot. But somebody can come and tell you, buy a CT, you will be getting 50 patients a week. You buy an MRI, you'll be getting 20 patients a week. And you buy it. You rush and buy it. No. That's not healthcare. That is not healthcare. Healthcare, again, is a business that is meant to be sustainable. And if I see you, that you have a track record, I'm willing to invest in you. But if I see you, Dr. Rosette, so what's your name? I keep pointing to both of you. Are you a doctor as well? Sorry, final year. You're a few days away from being doctor. Dr. Ayo, I see both of you doing 10 different things, but you are all doing the same thing, cardiologist and endocrinologist. But you come, CT, you come, MRI. At the back of my mind, you don't know what you are doing. You don't. Funding goes to people that know what they are doing. Believe you me. Please, let nobody deceive you. You know, we've spoken here, we said so many things, but I have been in this industry for long enough to tell you, money, I've removed funding, I'm now breaking it down. Money goes to who knows what he is doing. When you think about it, why are the banks ready to give money to Chicken Republic? Because Chicken Republic, they know what they are doing. What's their target market? No, not students. What's their target market? Every Nigerian, thank you. That's their target market. But that's us in healthcare, that's not our target market. Our target market is to put a nine parameter hematology equipment when you don't need it. When what you really need is 3 parameters. Really, you can't put 9. I want to show that I have 9 parameters. Now, it won't come to you. Money goes where there is sense. Please take it from me. Now, today, believe you me.
All right, thank you very much, ma.
Sorry, I think I would also lend a voice to co-panelist that said, because she has spoken phenomenally well. To be honest, I think that funding is probably not coming to the healthcare sector, because if you take, for instance, the fintech, you see them come out today and say, I just closed $500,000 in funding, Series A, Series B, and all that. It's because they have shown that they know what they are doing, like you said. They have shown it. For instance, if a VC wants to invest in a fintech, you have a checklist of everything that you need to have checked. Have you gotten this license? Have you done this? Have you done that? Have you tied in all your contracts? You know, all of those things. There's a thorough examination that goes into all of these fintechs before they are even funded. So if you can show a continuous track record of being able to have met all of the parameters that will attract funding, funding will come, definitely. Thank you.
All right, thank you very much. Mr. Elijah, are you still with us? Is he still there?
Yes, I am here.
All right, so can you just give us a 1 minute summary, 1 minute summary of the aspect of funding that we've just discussed? I mean, how do you think health facilities can get funding to acquire the in vitro diagnostic equipment that you deal with in just 1 minute? So we use that to close the panel session.
Okay, thank you. So it is 2 ways. One, the capacity of the facility involved, and then this is in terms of public facility, right? The capacity of the facility involved and the involvement, the intentional, the deliberate involvement of the federal government to support financially this institution, right? Now, what I mean by the capacity of the institution involved, it also covers for the integrity of the institution, headed by the chief medical director that has the final say. They must be responsive enough to meet to the understanding that has been signed and kept, right? Also, when the particular CMD's tenure is over, the incoming one should also have the intelligence to continue from where the previous one stopped. For instance, we've seen a situation where we've had an understanding with his current serving CMD, and because the CMD is exiting, the incoming one does not continue the arrangement that was there ab initio. So these are situations. So a solution would be responsibility on the part of the institution, including the lab, right? Giving the direct, being truthful on the costs and the ROI generated from the lab, the integrity of those in financing, and overall the CMD's quickness, promptness to keep to the signed MOU. This will encourage healthcare vendors like us to keep business afloat, because salaries have to be paid. We have increasing overhead costs. I know of a certain IVD company in Lagos that they prefer to deal with private centers than public healthcare because of these issues that I just outlined. So the discipline inside in the part of the facility, and then the support of government to encourage PPP is what we would need to scale up in this challenge. Thank you.
All right. Thank you very much, Mr. Elijah. We appreciate your insights and your presence virtually. And also thank you so much to my co-panelists here physically. So we have now officially come to the end of the panel session. So I want to also appreciate everyone for their questions and for also listening attentively to the panel session. Please, just in case you have other questions, you can always meet with them outside, or yes, and then discuss with them. All right. Thank you very much.
Thank you so much. Thank you. Thank you very much, our panelists. Thank you to every single person that has waited this long. At this point, I would call on Dr. Habib Moshood to give the closing remarks so that we can wrap up the event.
Thank you very much. Once again, I'll start with appreciating our lead sponsors for the event, Uni Medical. They are doing a very fantastic job in providing access to quality medical equipment and consumables. For one, I've very much used their gloves and their sutures during most of our surgical procedures. For doctors that are in the house, you can please engage them. They also have in vitro diagnostic solution equipment that you can always use in your various diagnostic centers. And so also a very big thank you to Oncopadi. They are doing fantastic work in digitizing access to oncology care. So oncology care is a very vital care in this part of the world that we need more people to get access to. So we very much appreciate everyone that have supported this event, from Lakeshore Cancer Center to Avon to Lotus Capital to Jackson, Etsy, and Edo. And to all our speakers, they've contributed, very vital to the discourse of the event. And we're not going to stop at this. We are going to take up whatever idea that we have generated from this event to engage stakeholders that will help implement them. So most importantly, we want to appreciate you that have, taken your time out, traveled far and wide to sit today, to listen, to be part of our event. We look forward to future productive engagement. Thank you too to everyone that has worked with us to put this together. I've worked with a very fantastic team, and we have been doing this over the years. I really appreciate you. Thank you very much. Thank you, everyone. Do have a very wonderful day. So please, you can walk up to the booths, Unimedical, Oncopadi, please engage them. They are very fantastic things to talk to us about.
Speaking through our achievement, what we're doing to the entire workforce and the entire environment that we service, could you please talk us through some of the CSR activities and different initiatives around maintaining a safe environment for our visitors?
Yeah, thank you for that question. So in Unimedical, one of our global overarching strategy is towards the environment. And in line with that, Unimedical we have invested in solar-powered facilities. For example, we have invested in a cold chain facility that is powered by solar, just to show our commitment to the environment and responsibility, just in line with keeping you safe. Also, our various offices, we're also moving towards making sure they are solar-powered, and that would be considered one of our CSR, making sure that the environment is safe.
What a great initiative. Thank you so much, GM. And as we are speaking through all of this, there is a question that keeps running through my mind. And we have a lot of success stories. We have amazing team doing all of this. Our customers are happy. But what's the plan for 2025?
Yeah, thank you, Anu. That's a great question. So 2025 is all about taking things to the next level. Because 2024 we have laid foundation for a lot of things, and in 2025 we've outlined a few key areas we are going to focus on, which includes improving on our processes, our products, and people. And then these are the key things we're applying to do. So when we improve on our processes as an ISO certified company, our process need to remain optimal in line with international standards. Then, of course, our people, our products rather. So we need to continue to improve on our product, not just getting products in the country because of, but there needs to be value for the products we are developing, bringing into the country to make sure that we deliver on the promises we're making to our customers. And then, of course, the people will keep on improving on the people and the culture of the organizations to make sure that our people need to serve our customers best. It goes a long way to making sure that we attain a 5-star rating from 2025.
Thank you so much, GM. That's so inspiring. So that means 2025 is already looking great for Unimedical teams and then our customers out there. So it's all about people, processes, and products. Thank you so much, GM. So now, as we wrap up our conversation today, what is your Christmas greetings to our entire workforce and the customers out there?
Yeah, thank you, Anu. And I wish to thank the whole Unimedical family for their dedication and their hard work this year. Next year is a promising year, and I know that together we'll make it big, make it successful. And I also wish the Unimedical family and all our customers a wonderful Christmas season and a promising year ahead. Thank you, everyone, for being part of our journey, and I wish you to stay safe. We look forward to accomplishing greater things together in 2025.
Thank you so much once again for making that time to speak with me. And on behalf of the entire crew at Unimedical and myself, Anu Adewale, Head of Corporate Services, we say Merry Christmas and see you in 2025.